Welcome to the NZUSI Resident Assembly for this year 2026, and it's a unique program designed specifically for the residents, specifically for exam purpose. It is divided in 5 parts. First is clinical case discussion. It is a kind of a ward round we generally take it during the exams for the MCH or DNB residents. Then the next one is a journal club. And then we have included a surgical craft video where most commonly performed procedure is shown and taught through a video series. And then some uroradiology questions and one drug spotlight, most commonly used drugs used for a urological program. So to kickstart the first session, that is a clinical case presentation. The presenter is Dr. Devesh. He is a third year senior resident from PGI Chandigarh. He'll be presenting a case of flank pain, and it will be two residents, Dr. Vignesh from RML and Dr. Prakhar from SGPGI, will be taking will be questioned as a examinee, and the examiners for this session are Dr. Amlesh, Seth, Dr. Nachiket, Vyas, and Dr. Ravimohan from PGI. Dr. Devesh. Dr. Devesh, can you share your screen and start the program?
Is the presentation visible and am I audible, sir?
Yeah.
Yes, Devesh. Yes.
So the case is a 57-year-old male. He's a resident of Ambala, Haryana. He's a shopkeeper by occupation. He presented to us with chief complaints of right flank pain 1 year back. History of presenting illness. He was in his usual state of being until 1 year back when he developed right flank pain, which was sudden in onset, mild to moderate in intensity, dull aching in character, radiating to the groin, and was associated with nausea and burning micturition. The episode of pain lasted for 1 hour and was relieved with oral analgesics. There was no history of associated vomiting, no history of hematuria or associated lower urinary tract symptoms, no history of pyuria or fever, no history of graveluria. There was no history of decreased urine output, facial puffiness, shortness of breath, or requirement of dialysis. No history of chronic use of nephrotoxic drugs, and no history of chronic limb ache, backache, or any mood disorders.
Examiners can take over, Nachi. And
Yeah.
if
So
Amlesh, Seth sir are
based
there,
upon based upon the clinical presentation and the history of present illness, what DD comes into mind? I mean, who's with us? Maybe the Devesh and
Dr. Prakhar and
Yes, sir.
Vignesh are there.
Yes, sir. Am I audible, sir?
yeah, you're audible.
Yeah, Dr. Prakhar this side, sir. Yes, sir.
Yeah, batao.
Sir,
can you switch on your camera, Prakhar, please?
yes, sir.
Camera,
Beacons.
Just a minute. Am I visible, sir?
Yeah.
Yes, you are.
Okay, thank you. Sir, on the basis of the age profile of the patient, 57-year-old male with having a right flank pain, sudden flank pain, my first diagnosis would be of a renal stone disease, sir.
Okay.
And furthermore, sir, it could be there's no associated history of fever, nausea, vomiting. So I would like to rule out the inflammatory causes or the infective causes. And it could be a renal cystic disease, sir. It could be a Pujo, because the patient also has a dull flank aching pain, sir. Yes.
No, but there was radiation also, no? He said
Yes,
that there was radiation to the
yes, sir.
groin.
My first diagnosis is of a renal stone disease, sir.
So renal stone. So a renal stone. Do you think that a renal stone disease would also have radiation towards the groin? What type of urolithiasis can cause flank pain with radiation to the groin?
Sir, upper ureteric calculus, sir. Pujo calculus.
Okay.
Yes.
Can it be a ureteric calculus also? I mean, mid-ureteric
Yes,
or
sir.
lower ureteric calculus?
Yes, sir. It could be, sir.
Why did you say upper ureteric calculus? Is because upper ureteric calculus would have radiation just to the flank. When does a ureteric calculus also have radiation to the groin?
Sir, a mid and a lower
Ureteric
ureteric
or lower
calculus
ureteric?
irritation. Yes, sir.
So, Prakhar, who is the other resident? We can ask some questions to him.
Sir, Vignesh
I
is
think
there
Sir
from
Vignesh
RML.
is there, sir.
Yes, sir.
So, Vignesh, yeah, hi.
Yes.
So, do you agree with Prakhar or you have something else in mind?
Sir, usually mid and lower ureter radiates to groin, sir. This patient is having radiation to groin along with Nausea was also there for the patient,
So
and the
do
pain
you
relief.
expect a renal colleague to have this kind of dull aching pain? I mean, a ureteric stone which will have a radiation would have a different kind of pain, or would be like this pain? The pain would be like this.
So, it's usually not the leaking, so it will be a
Correct.
sharp pain for the patient.
So you want to add on some more diagnosis then, differentials? 57-year-old male. Prakhar said stone disease, cystic disease, Peugeot.
Sir, but the patient does not have any hematuria or lower urinary tract symptoms. So malignancy is less likely. I will keep it as a last differential diagnosis for this patient, sir. Apart from that, the patient does not have fever or pyuria also. So urinary tract infection can also be kept as a DD, but it's less likely, sir.
But why did you say hematuria? I mean, you said that the patient does not have hematuria, so I'm not going to keep malignancy. Do you get hematuria in all cases of malignancy?
I will keep malignancy as a last diagnosis, sir. Less likely.
Patient might be having microscopic hematuria.
Yes, sir.
So how can you say that the patient is not having hematuria? What you mean to say is not having any visible gross hematuria.
Yes, sir.
Gross hematuria is only seen in 60% cases of RCC as a clinical symptom. Not always you will get hematuria. Still he can have malignancy, no? So don't say that because he has not got any hematuria, so that's why it's difficult for him not to have malignancy. It's not that way, no?
Yes.
So I think let's move on. But Prakhar, as an examiner, we at 57-year-old old keeping cystic disease as a second differential and
Yes, wrong.
Peugeot as a differential may not be very appropriate. You could have kept renal stone, agreed, because that's the most common. But then malignancy should come up as a second differential, and then we move on to the other to complete the list. So your DDs were more like completing the list, but 57 years in perspective has to be malignancy has to come
Malignancy.
as.
Okay, sir.
Okay. Okay, let's
Yes.
move on then. Sir, shall we move on then?
Devesh.
Yes, please. I think that please let's go on. Amlesh sir is also here.
Past history. He's a known hypertensive on currently on medications. He has history of coronary artery disease post LAD stenting in 2017 on dual antiplatelet drugs. And he gives history of some surgery done in the neck 9 months back for some hormonal disorder. Family and personal history. There is no history of malignancy in the family, no family history of stone disease. He's a vegetarian by diet. He's married with 2 children. He has a normal appetite with normal bowel and bladder habits. He's a non-smoker and there's no history of any alcohol intake, and he has a normal sleep-wake cycle.
If you want to take a family history, then what is the way you're taking the family history? How would you take a family history? For how many generations? See, if you make a family history tree, then there has to be, a vertical family history tree and then a parallel family history tree. Because it's important in the case of malignancies. Can any resident tell me how to take family history? How many generations you want?
Yeah, Prakhar or Vignesh, be active. Let's not waste
Yes,
time.
sir. Sir, at least 2 generations, sir.
Yes, vertical 2 generations and also horizontal up till second generation, until second cousins
generation,
you
sir.
should take
Yes,
family
sir.
history.
Yes, sir.
That is the grade in which how the family history has taken, especially in case of malignancy, na?
Malignancy, sir. Yes.
Right.
So
Let's go on.
Vignesh, you want to know something more in the history?
Sir,
Sir, I want to know that the neck surgery that was done for the patient, do we have any further details of that? Or the patient had evidence of stone disease before that also?
So should I respond?
Yes, he's asked you a detail.
Yeah, he was found to have elevated calcium levels, and further evaluation, he was found to have a parathyroid adenoma, for which he had undergone parathyroid adenoma excision. That was the surgery that is.
Before that also he had any history of lithuria or any ultrasound that he
No.
got done for a stone disease or anything like that?
No, so the first evaluation was done when he had developed flank pain 1 year back. The evaluation for hypercalcemia and any ultrasound or imaging was done after that episode of pain.
So at the time of parathyroidectomy, no USG or anything was done.
So the ultrasound relating to the kidney or relating to the parathyroid adenoma.
Yes, relating to the kidney, to the abdomen.
Relating to the kidney, yes, the ultrasound was done. That is, I have shown in the after the examination.
Fair enough. So on history, based on the end of the history, Vignesh, you've been silent. What is your diagnosis now?
Parathyroid adenoma surgery was done. Whether total all the glands was removed or only the adenoma was removed, and what was the calcium and PTS level post surgery, whether it was evaluated, I want to know.
Okay, I think that he will present in the biochemical parameters. But based on history, what is your diagnosis now? You want to keep only one? You want to keep multiple, or what?
Sir, I would keep renal stone disease with plus or minus ureteric calculus also as my primary diagnosis, sir. Based on examination.
About you, Prakhar?
Renal stone disease, sir, because the patient has a concomitant history of a parathyroidectomy, could be because secondary to hyperparathyroidism.
Fair
So
enough.
very
So
likely,
you can say
very
renal
likely.
stone disease with the possibly primary hyperparathyroidism. That would make
Yes, sir.
make it
Yes,
kind of
make it up.
diagnosis, because in
Yes.
history of neck surgery is
Yes, sir.
almost
And
like
the
bleeding.
sudden flank pain could be explained by any renal calculus moving into ureter that must have caused this acute event by which he presented to us.
What is the unique feature of renal stone disease which are associated with hyperparathyroidism?
So they are mostly the multiple bilateral renal stones, recurrent
Yes, they're
stone
usually
formers,
multiple, they're usually bilateral. So that's why
multiple.
now you should think of that maybe the patient might be having a bilateral pathology. It's very
Yes, sir.
common for stones to be present in both the kidneys in hyperparathyroidism.
Yes, sir. Recurrent stone
Associated
formers.
adenoma.
Yes, sir.
But still
Yes, sir.
at this level, you should not rule out malignancy, because many times
Correct.
parathyroid adenomas can be associated with even malignancies of the thyroid, like medullary carcinoma thyroid, even RCCs, and even pheochromocytoma. So it can open a hole. There are multiple syndromes in the men's
Yes, sir.
syndrome in which the patient can have all these features. So still you should not rule out a malignancy.
Okay, sir. Thank you.
Yes.
Yeah, let's move on.
On general examination, he was conscious, cooperative, and oriented to time, place, and person. He was hemodynamically stable. His height was 170 centimeter with a weight of 74 kilograms and a BMI of 25.6 kilograms per meter square. He did not have any pallor, icterus, cyanosis, clubbing, or lymphadenopathy. And a horizontal scar of surgery was present in the neck. On systemic examination, abdominal examination, on inspection, the abdomen was normal in shape. The umbilicus was inverted and central. There was no scar or any swelling seen. On palpation, the abdomen was soft. There was no renal angle tenderness, no palpable mass or organomegaly. The abdomen was tympanic on percussion, and bowel sounds were present. The rest of the systemic examination was grossly within normal limits.
Fair enough. Anything else you want to ask, guys?
Sir, then neck examination was done to whether any nodules are present in the neck.
So the examination has been done after the primary surgery. Other than slight induration along the scar side, there was no nodule that was palpable.
Any bone pain history?
No, so retrospectively on history taking, he did not
Any
give any history of chronic bony pain or any mood disorders.
muscle weakness, bilateral lower limb weakness, nothing like that.
No.
I think we'll move on. Nothing further, yeah.
On the laboratory investigations, these are the investigations that were done prior at the first presentation during the episode of pain. On complete blood count, his hemoglobin was 11.1, counts were 5,600, and platelet counts were 3.8 lakhs. Electrolytes were within normal limits. The potassium was 4.9. On renal function tests, his urea was 68 and creatinine was 3.02. LFTs were normal and albumin was 3.2. His calcium levels were elevated. They were 10.96. And IPTH and phosphate was 3.02. PTH was 172 picogram per ml. Vitamin D3 was 42. Uric acid was 4.8 milligram per deciliter. On urine routine, 10 to 20 WBCs per high power field were present, with 3 to 4 RBCs per high power field, and no crystals or casts were seen. Urine culture was positive. It was E. coli, which was pan sensitive to all drugs.
Yes, guys.
What was the sensitivity of the urine culture colony count?
So the colony count was more than 10 raised to the power colony forming units per ml, and it was a pan sensitive E. coli, sensitive to almost all the drugs that were tested.
Okay. So, sir,
You
the
think
urine
that
calcium,
the
urine
PTH
calcium is
levels are
elevated, the
normal?
IPTH is elevated.
I'm sorry.
Calcium and IPTH both are elevated.
Yes, the PTH levels are still elevated despite parathyroid surgery.
No, sir, this is the laboratory
This
values
was before
prior
the.
to the parathyroid surgery. That is what I
Prior to the
just at the
parathyroid surgery.
yes, this is the first.
Okay, right. I thought
I've
that they were
included the
already
treatment
you were
history after
presented
the
that the
initial imaging.
parathyroid surgery was done.
So Devesh, as an even when you conduct an exam, just remember that this is confusing to the examinee. So you could have simply presented the present values, and when the candidate asked that what was the values before, then we could have actually deliberated on that. So right now, I also got confused that
So-
despite surgery, this is elevated. So let's have the present biochemical because patient has presented to you now, not prior.
I just want to make
yes.
a point because the impression that you get on this PTH is that either the parathyroidectomy has been incomplete or the patient might be having a tertiary hyperparathyroidism state in which there is an autonomous parathyroid secretion from the thyroid gland. So that's why it's important to tell the correct levels what has happened now.
So at present, post parathyroid surgery, when this history was being taken, he had undergone his creatinine was 2.1. Electrolytes were in the normal range. His calcium was 9.5 with a PTH level of 55.
Okay.
And cultures was dry.
Okay. So patient basically is in CKD, and so now what you want to do? His creatinine is roughly at 3.02. What is his creatinine?
Yeah,
Sir,
3.0.
he underwent DJ stenting for. Actually, I had included all this after the imaging findings. So he had undergone some endoscopic procedure, following which his creatinine had dipped to 2.1 from 3.02.
So now he's already undergone some kind of a procedure. So what is what is happening is that
Sir,
you're mixing half of the things that surgery has been done, and then you're mixing half of the things in which surgery, we're also getting confused about the creatinine present is 3.02. What is
so
the
the present
creatinine?
creatinine 2.1.
Okay, go
Present
back a
creatinine.
slide.
This was, sir, my apologies. I had included all the laboratory investigations that are included over here that were at the primary presentation before the prior thyroid surgery. So at present, during the history taking, his current creatinine was 2.1 and calcium was 9.5, PTH was 55 with an
Devesh,
albumin of 4.2.
yeah, very important point
My
that
apologies.
even when you take an examination, when you take history, when he presented to you in your clinic is your present history. So in those you have to act in that line, and then you
Yes,
can retrospectively answer ki these were the values before and these are the treatment history which he has undergone. Because otherwise, even as an examiner, we are also blinded to the case and we are analyzing as if the student is also analyzing and trying to mold him in a direction which is leading us to the diagnosis. So in that confusion should not happen. Just remember, it's true for every resident who is there for exam, that when you take a history and present it, you should be presenting in a way that it follows a storyline rather than coming back and forth. Just remember this.
Yes, sir. Sorry.
Okay, so still the patient is in CKD, his creatinine is 2. I think what would you do now? How would you manage? Patient's WBCs are 10 to 20.
I would start a radiological investigation of this patient by initially I will do an ultrasound KUB to look for any renal calculus and the renal parenchymal thickness and corticomedullary differentiation of the patient. So, followed by ultrasound is
Okay, do you have an ultrasound?
and
Yes,
urine culture is also positive. I like to start antibiotics for the patient, IV antibiotics preferably, sir, if the patient is admitted.
Okay. Okay. What could be the causes of the increase in WBCs in the urine? Do you think that there's an infective cause? Patient is having UTI. There can be other causes also for WBC in the urine.
So the patient has the patient has a stent in situ, I guess.
Even a stent, even stones. If you're thinking that the patient has stones also,
Yes, sir.
there
Yes,
also the patient can have WBCs. It can be a non-infective etiology. Patient is in CKD. They are saying some kind of element of even tubular interstitial nephritis can cause WBCs. So it's not necessary that the WBCs be due to infection.
Yes.
Okay, so do we have an ultrasound?
Yes, sir. This is the images of the ultrasound KUB of the patient. The right kidney was normal in size and ecotexture. The corticomedullary differentiation was intact. 5.5 millimeter calculus was present at the lower pole, and two calculi 5.5 and 9 mm in diameter were present in the proximal ureter with mild hydronephrosis. The left kidney was grossly hydronephrotic with the thinned out parenchyma. The exact parenchymal thickness was not mentioned. There was a 7 mm calculus in the proximal ureter. The urinary bladder was distended with internal echoes present.
Amlesh said, sir, please.
Yeah. What is the main issue in this particular case, which is different from the rest of the stone disease patients that you see?
So the patient has a associated hyperparathyroidism.
Yes.
As we all.
Hyperparathyroidism.
Yes, sir.
How common is hyperparathyroidism in patients of stone disease?
And
what percentage of patients of stone disease that you see will have hyperparathyroidism? Or in your experience of 2 years, 3 years, how many cases of hyperparathyroidism have you seen?
Not seen, sir.
Not
2 to 3 cases.
So obviously the answer is it is uncommon.
Yes, sir.
But amongst patients of hyperparathyroidism, how common is stone disease? Whenever you get such a case, even if you are not seen, you are supposed to know about the hyperparathyroidism. Whatever is given in Campbell's urology, you are supposed to know.
Yes.
So you should be ready with these answers.
Sir, around 15, 10, 15%, 15 to 20%.
20 to 25%.
No.
15 to
of all the stone diseases, 2% to 5% patients would have hyperparathyroidism. And on the contrary, if a patient is diagnosed to have hyperparathyroidism, then 1/5 of cases have stone disease. It's not as if in all cases of hyperparathyroidism, stone disease is present. But if you look at the etiology of your stone cases, the hyperparathyroidism would be found in 2%. The reverse would be 20%.
Yes.
Okay, now is the hyperparathyroidism issue resolved or it is still not resolved?
So at present, hyperparathyroidism is resolved. He has a normal serum calcium.
No, you look at the serum calcium. In what percentage of patients with hyperparathyroidism will serum calcium be high? And if serum calcium is normal, do you rule out hyperparathyroidism?
No, sir. We cannot rule out hyperparathyroidism on basis of normal serum calcium.
Okay, so now tell me again the answer to the same question. Is the issue of hyperparathyroidism resolved or not resolved?
The serum calcium is still elevated. It's at 9.6, I guess. But the IPTH has dropped to normal level.
9.6 though is normal calcium level. 9 to 11 milligram percent is normal. So why
It's
is calcium
10.6.
elevated 9.6 है ना calcium?
10.65.
It's not elevated.
Acha, it's within 10. Okay. So it has resolved, sir. So calcium has
even above 11.5 hypercalcemia, you would only level above 13 milligram percent. So it is not a case of hypercalcemia now.
Okay. So the calcium level has dropped. The IPTH has dropped to less than 50.
It has dropped to less than 50? Okay. So you think that this issue is resolved?
Yes, sir.
Okay. But you would definitely like to know the details of the surgery. So parathyroid, what was the diagnosis before, whether it was adenoma and how many adenomas were there? All those details, we should definitely find out. So all those details, are they known? Where was the surgery done? Was it done in a center where, from where a proper discharge summary has been given?
So the evaluation for the parathyroid adenoma was done at our own institution. On initial imaging evaluation, there was a suspected single left inferior parathyroid adenoma. However, the surgery was done at an outside institution. The proper documents are not available. Discharge summary is not properly given. However, there is a histopathology report which confirms a single parathyroid nodule was submitted, which was suggestive of parathyroid adenoma.
Okay, if there is hyperparathyroidism that is persisting and patient has stone disease, which one will get a greater priority?
Sir, if the stone is non-obstructive, it's not causing any symptom to the patient, then we should deal with the primary pathology first, sir, hyperparathyroidism.
Okay, but supposing if the stone is obstructing?
Sir, if the patient is symptomatic, the stone is obstructing, the patient is having fever, then we should deal with primary management for the stone concomitantly with management for hyperparathyroidism.
Concomitantly?
What do you mean concomitantly?
Sir, we should start workup for hyperparathyroidism as well at that moment and deal with the stone first.
If there is no infection and the patient's creatinine is 3.06 as it was in this particular patient, and patient is still hyperparathyroid, which one will you deal with first?
The patient having stones in the ureter, left kidney having a gross hydronephrosis as we have this, and creat elevated. So we should go for a stenting for bilateral kidney, sir.
Okay. Supposing it's a staghorn calculus, it's not a unique stone, then
staghorn calculus with a normal contralateral kidney, staghorn calculus in one kidney, patient not having fever. So we can wait, I guess.
Wait?
Why would you wait? Why, if this staghorn calculus becomes infected, then the kidney is going to be knocked out. There's going to be infection in the kidney. So you have, even if during evaluation of a patient has hyperparathyroidism, you have to make the kidney stone free. Presence of stone and infection, it is the worst combination for kidney.
Yes, sir.
You can take out and make the patient stone free and then send him for parathyroid. Stone would not form in 1 day, 1 week, 1 month. It is a slow ongoing process. You can manage the patient and then send the patient for his parathyroid surgery.
And
Even in the presence of staghorn, Dr. Saab, are you going to wait for the kidney to get some kind of infection? Kidney will get quickly knocked out. You cannot send a patient with staghorn and say that you are going to wait.
if the serum calcium is say 10.9 or 11.1, which one will be a bigger issue, the staghorn calculus or the calcium of 11.1?
Staghorn, sir. Staghorn.
Staghorn, no.
Sir, पूछ रहे हैं, what are the problems of hypercalcemia that the patient can develop? If the
No.
patient is hypercalcemic, क्या problems हो सकती हैं?
If the parathyroid adenoma is still there, hypercalcemia and parathyroid adenoma, they assume a greater importance because there can be many perioperative issues in patients with hypercalcemia. And the other thing is the recurrence of stone disease is also very rapid in a patient who has persistent hyperparathyroidism. And therefore, the answer to this question, it is given clearly in Campbell's, and that is first you have to deal with hyperparathyroidism. First, you have to remove the adenoma, then take up the patient for surgery.
Yes.
You know, this rule is an old rule. It is something which has been mentioned for
Again and again.
a long time. And these rules obviously get modified with time. This rule was made at a time when there were no stents available. PCN was not available. Open nephrostomy was the only method. So now the rules obviously get modified. And if you can do a minimal intervention like a double J stenting or a PCN and stabilize the patient and then take the patient up for parathyroid surgery first. And then, like right now also, there are stents. So after the stent, supposing he had come to you with the parathyroid intact, what would you have advised him? A ureteric stone surgery first, or you would have told him, no, go to the endocrine surgeon, get your parathyroid out, and then come back to me.
Parathyroid first, sir.
Yes, that is the issue that I wanted to point out and talk about.
So you guys have mentioned it very correctly that, what we wanted to emphasize, Amlesh sir has put
Yes,
it that if it's the calcium levels which determine the risk of anesthesia, and that's how you would decide what should be done upfront. So if the hypercalcemia is there, it is an anesthetic risk. You must manage the hypercalcemia because cardiac asystole is a known problem with hypercalcemia. You have to manage that, and then we could have discussed all the measures to manage it as an emergent process. Then tackle the parathyroid, and then they do the surgery. In between, if the creatinine is elevated, manage it by stenting or PCN or something. That is perfectly said. But if the calcium levels are normal and patient has a stone, then and symptomatic, as you rightly mentioned, Prakhar, then stone surgery can be offered up a priori before parathyroidectomy. So either is okay, but both have to be managed. Which one to do first is what we wanted to have a clarity.
I think Devesh, you can move on to the case now. Yeah.
How would you grade hydronephrosis based upon sonography? Any of the residents can tell?
Sir, there's an SFU grading for hydronephrosis grading.
All of you should know it, na? Because SFU
Yes,
is
sir.
also applicable in adult patients. So what is SFU 0, 1, 2, 3, 4?
Sir, SFU 0 is normal. SFU 1 is renal pelvis is dilated and the calyces are not
No,
dilated.
this is exactly not. The pelvis is not dilated. First
Yes.
of all, there will be a splitting of the central echogenic
Central.
renal sinus.
Yes.
Renal sinus has fat, so directly the pelvis would not be splitted. How it
Yes.
has been described as separation of the central echogenic sinus.
Sinus.
Then you have dilatation of pelvis and all. This is one mistake that sometimes occurs. So it is not dilatation of the pelvis. Then pelvis, then after the pelvis, the major calyces, then minor calyces with an involvement of parenchyma, right?
Yes. Yes, sir. Minor calyces and then parenchymal thinning, sir.
Yes. Okay, go on.
Thereafter, a non-contrast CT scan was done for the patient. The findings are as shown.
A large ureteric calculus on the right side, and also a ureteric calculus on the upper ureter on the right side. And also lower calyceal calculus.
The right side.
And on the left side?
A single calculus in the left proximal ureter was present, which is seen in the second image on the leftmost.
This one, yeah. Okay. So now what would you do? Right side, lower calyceal calculus, upper ureteric calculus, right side, lower ureteric bill calculus. अब क्या करोगे?
Based on this CT, left side appears non-functional, sir. And in right side there is multiple ureteric calculus, upper ureteric calculus, and a lower pole calculus is also seen. I would like to do a right side stenting for right kidney.
Why did you say that it was non-functioning? This is not a contrast study.
No, sir.
It can be polyfunctioning. It can be polyfunctioning, but why non-functioning?
Sir, for right side, I will do a stenting, and left side, I would like to do a PCN insertion. And I can measure the urine output, 24-hour urine output and urine volume, and I can calculate the differential function also to see whether it's functional or not.
See, there's such a big stone on the left, on the right lower ureter. Say the stent does not go then.
Since creatinine of the patient is elevated, my primary focus will be to divert the urine. I would either go for a early uracil or percutaneous PCN insertion on the right side.
Prakhar, you agree?
Sir, I would like to go for a right side DJ stenting and a left PCN insertion, sir.
No, Nachiket sir put a point that stone on the right side is big and you're not able to put a stent. So Vignesh said, I'll go for an early URS. What is your thought?
I would go for a PCN insertion, sir, then.
Yeah. So I think, Vignesh, the point is that we have to optimize the renal function before you do anything. So for optimization, whether stenting or PCN, whichever is necessary, should be done prior. Once the creatinine is stabilized, then you decide for a definitive treatment. Because in a positive urine culture with CKD and you do an early URS, you might get stuck with a situation where patient goes into ATN and never comes back. So remember that.
Yes, sir.
So
how would you put a PCN on the right side? There is a large stone in the right lower ureter, stone inside the right upper ureter. How do you put a PCN?
Right.
Do you have any thoughts when you want to say put a PCN with respect to management in future?
Sir, I would like to approach. I would like to take a middle calyceal puncture while putting the PCN, so that.
How do you know that it is a middle calyx? You are doing PCN and say that UCAT is not going, and because it's an obstructed stone. So how would you?
Ultrasound guided.
Are you using ultrasound routinely in your department for PCNLs?
Yes, sir. PCNL we don't use, sir. For PCN insertion, we do ultrasound guided only, sir.
If you are doing ultrasound, then how do you know which calyx is which? How do you identify posterior calyces and the anterior calyces on ultrasound? So you said you want to use the middle calyx to put in a PCN. So then you have to identify the posterior set of calyces and the anterior calyces. On ultrasound, how do you identify the calyces? पता है या नहीं? तो हाँ बताओ. When you put your planar probe inside the craniocaudal direction and you move it from the spine laterally over the kidney, then the first set of calyces which are visible are the posterior calyces. The posterior calyces would be, visually, this is because they are towards the back. And after that, you can see those calyces. If you want to put it, then use it. If you go more laterally, then the next set of calyces which are visual, these are the anterior calyces. That is how you identify on ultrasound, which is the posterior and the anterior calyces. And the more you do ultrasound for PCNL, the more you start understanding the calyceal anatomy. So you should do it, everyone.
Yeah. Devesh?
After the findings of the imaging, different EC scan was done to understand the functioning of bilateral kidneys. The renogram curve is as shown. The left kidney had a split function of 8% and was poorly functioning, and the right kidney had a split function of 92%.
आगे चलो देवेश।
तुमको रीनोग्राम करना था, इसीलिए तुमने है ना नॉन कंट्रास्ट सिटी पे बोला लेफ्ट किडनी इज looks like non-functioning, because most likely you knew the renogram. Otherwise, on NCCT, you cannot comment even just by looking at the cortex and the medulla whether this kidney is functioning or not. इसलिए मतलब the case तुमको शायद पता होगा पहले.
Sir, there was no parenchyma in that non-contrast CT.
कंट्रास्ट तो था ही नहीं ना, NCCT था, तब तुमने बोला था कि लेफ्ट seems to be non-functioning. चलो अब ये है, this is the situation now.
Go on.
This is the treatment history following the first presentation. He was evaluated and then treated for hyperparathyroidism. For this treatment duration, bilateral DJ stents were placed, and his creatinine post DJ stenting was 2.18, which has already been covered previously. This is his current X-ray KUB showing the right bilateral renal stones as well as the bilateral ureteric calculi.
How many weeks after diversion, be it internal or external, do you want to go for definitive surgery inside these cases, if there is no infection?
So once the nadir creatinine is reached, and after 3 to 4 weeks, sir.
Yes, 3 weeks is minimum, because then you have the whole gambit of the diuretic phase, recovery phase.
Yes, sir.
So that's why the improvement of renal function more or less gets fixed in 3 weeks.
Yes.
So then after that, you can plan the definitive surgery. बोलो क्या definitive surgery करेंगे? In which side you want to?
Sir, right side is the better functional kidney, sir, having a split function of 92%. So would lead to deal with the right ureteric stone and right renal calculi, sir.
क्या modality? What modality you want to choose?
Sir, the patient has a history
use?
of the patient has a history of CAD, sir. He was on DAPT and has been done on PTCA has been done previously. So would like to use post DJ stent removal. Would like to deal with a URSL for ureteric stone, sir.
Flexi URS, no?
Yes, sir. Flexi URS, sir. Would like to avoid PCNL in such a patient.
Nachiket will have to stop also, because we were supposed to finish by 11:10. Next team would also be waiting.
Sir, 11:20 का time था, sir. So I guess we are right on time, sir.
I thought 11:10. Girdhar?
No, sir, we can stop now, sir. Time हो गया.
We can till go to 11:20 with including 2-3 minutes from the comment box, sir. So we still have 3-4 minutes, 5 minutes more because we started slightly late, because so we can have 5 minutes more to wind up the session and take the questions from the comment box here also. Yeah. So any other further, Vignesh, do you have any other different plan than him, Vignesh?
Right URSL, PCNL, I don't think for a CAD post PTCA also PCNL can be done, sir, if other parameters are normal. So the PCNL should be avoided in this case.
Do you think in URSL you will be able to clear all the ureteric stone in a
No,
single?
it's difficult to clear in a single settings and might require a staged URSL since
Yeah.
multiple
I
stones
think
in
the
the
point to be to for you guys to remember here would be that you would not do a nephrectomy upfront unless it becomes prohibitive with respect to pyenephrosis. You try to manage the stone for the proper, better functioning kidney first, and then decide for the nephrectomy. And as you rightly said, Vignesh, URS, flexible URS versus PCNL would be depend on based on the size of the bulk of the stone. But the aim has to be that you to clear the entire stone. So fair enough. It's not like a PCNL is contraindicated or should be avoided. I don't think we should use such terms in stone disease management. Anything which any armamentarium, all the armamentariums, you would have preferences, but the aim is to clear the entire stone. So whichever you want to use, fair enough.
May I pitch in? May I say something? Dr.
Sir.
Mandani here.
Yes, sir.
Okay. So good morning, everyone. Two things I would like to differ from the presenter or the examinee. One is PCN decision, and second is decision of EC. You see, EC and DTP I have seen in practice, a lot of them are getting them done, but I don't think there is any role of these two tests in young patient with ureteric stone and obstructed kidney with creatinine of 3. There is absolutely no point. May I ask the guy who wanted this EC scan, how did it make the difference in management? That is one. The PCN, unless there is fever or pain, I don't think in this particular situation, PCN decision would have been right. So these are the 2 points I would like to mention because I would have not done either PCN nor EC.
I think that any kind of an imaging, a radionucleotide imaging in the setting of a bilateral pathology and a patient who's already in CKD, sure, I totally agree that it's not always necessary. This is because your primary focus is always to save the kidney as much as possible. The threshold for a nephrectomy should be very, very high, even in kidneys on sonography and on CT scans, which are looking as very, very poorly functioning kidneys. But unless there is no infection, the threshold should be kept very high because whatever contribution is there, be it 10 ml per minute, 15 ml per minute, but at least there is a contribution. So if the patient is not having recurrent infection, recurrent pyelonephritis or pyelonephrosis, then I don't think a nephrectomy should be done inside these stone diseases. We see plenty of them in Rajasthan, which is a big stone belt. So I agree with Dr. Mandani that maybe an EC or any type of radionucleotide study would not, have added to anything in the place that I work. But I think that RIRS, yes, looking at the size of the ureteric stones, and also I think that it is applicable even in a single setting. So that would be a very personal choice depending upon, how you are doing inside the department. But I think that RIRS would be a good choice inside both the sites. But yes, PCNL can be done. 2.18 with aspirin clopidogrel is not a big issue. A mini PCNL can be done, but this is very individualized.
Sir, having bilateral stent placed and getting an EC scan done after that.
I want to make comments regarding this. Number one, in very poorly functioning kidneys, the EC scan may not be helpful. But with a creatinine of 2.1 or 2.18 or even up to 3, the kidneys will not be that poorly functioning, and therefore an EC scan would definitely be helpful in finding out what is the percentage function. Second comment that I want to make is we have discussed this issue regarding this renal function and creatinine and EC scan with the nuclear medicine department on a number of occasions. The rough guide they tell us is up to creatinine of 3, it is acceptable to do an EC scan. Beyond that, it may not be useful because the background activity will mask the renal function and percentage function may not be reliable. But up to a creatinine of 3, definitely go ahead and do an EC scan. Second thing is regarding the stents. The problem with the stents is that stents are obviously two-way communicators. The the urine can rise up also. So therefore, you should put in a Foley's catheter, and the Foley's catheter should be draining freely when you get the EC scan done. Otherwise, the reliability of percentage function is not good because urine from one side may get refluxed into the opposite side.
So
Yeah,
the
we'll take
bilateral
last
stent
comment
with a
from Dr. Kamaljeet Singh, sir, and then we'll wind up this session. Dr. Kamaljeet, your last comment, sir.
You can continue the discussion on chat box,
Yeah,
please. It's an interesting
I will
discussion.
just move little away. There's a little noisy in my side. I just want to make a comment regarding the renal scan. It all depends upon the which area you're working in. If you're working in an institute, then you can skip it. But in a private practice, I will always recommend to get an EC scan to document it at least that the kidney is not functioning. There are a lot of blackmailers who come and then trouble you post-op in the post-op period. So my take is, yes, you need to save the whatever renal parenchyma or the functional renal parenchyma you have. But in private practice, those who are going to go into the private practice, this will be a safety investigation for you. Thank you.
Thank you so much,
Dr.
sir.
Bora,
Thank you all
can
the
I,
yeah.
Dr. Bora, I just wanted to make one small comment. Sorry for
Yes,
barging
sir.
in. The point is, Dr. Mandani and Kamal, sir, everyone seems to be right, but for examination's sake, the first step aim is to optimize the function before EC scan. So that's what the resident made a mistake. They should have first put a stent, optimize the function, and then after 4 weeks do a scan if the parenchymal thickness is poor, only for documentation sake. It was never a mandatory investigation in the entire process of managing the stone. But then, as Dr. Kamal pointed out, and we also, even in institutes, we keep on seeing patients being treated by stone disease, and then they come back with non-functioning, and we are not sure. And the patients do come back saying it's because the surgeon did something wrong. So it's safe, but it's not the investigation to be uttered in the beginning. It has the first aim is to optimize the kidney function, have a very high threshold for nephrectomy in bilateral stone disease. These are the messages which should be clearly taken up. Thank you.
Thank you, Ravi, sir, for
Thank you,
summarizing.
everyone.
And now will be quick. Thank you all the examiners or the exam going residents and Devesh. And we'll be moving on to the next session. There is a slight change in the session. We will be taking the part 3 session, that surgical video first, and the JC at the third. Apologies for that. And I request Dr. Rahul Gupta, is a consultant urology at GMC Jammu, to present his video on various techniques of TURP. The experts for this session are Dr. Arif Hamid, Dr. Gautam Chaudhary, Dr. Pauva, and Dr. Rishi Nair. Dr. Rahul, please.
Yeah, good morning, everyone. First of all, thank you very much, NZUSI, Dr. Sameer and Dr. Girdhar, to have me here. I am audible?
Yes, you are.
Yeah, and my apologies to barge in because of some personal reasons. Thank you for accommodating me. So today, the thing which has been designated to me is the technique of TURP. And again, as this is being discussed, this presentation is only for educational and exam going purposes. So I'll be answering a few questions whenever we ask the questions to the residents, how they have to approach regarding this question about technique of TURP. There is no conflict of interest and no instrument is being promoted in my presentation. This is only for presentation. So domain of today's talk would be armamentarium, absolute basic, relevant anatomy to TURP only, stepwise approach to prostate resection, basic to the end, the position, drape and the procedure, different techniques which have been described in the literature, special situations, like we asked from the candidates, what do you do in a large median lobe or large prostate extending beyond the verumontanum, and how to control the bleeding. So coming to the armamentarium, there are basically two types of armamentarium which we use for TURP. And if somebody asks you for a TURP, it is either a monopolar TURP or a bipolar TURP. Invariably, there will be the instruments in the instrument tray, and the examiner would and should also ask the candidate to assemble that. And anybody who fumbles in assembling these instruments is unpardonable. So I would request all the residents to learn how to assemble whenever they are assisting their consultant, or at least at the end of the procedure, disassemble the assembly so that they know what are the parts of the instrument which are being used for the TURP. So commonly used sheath, if somebody asks you, it is a 26 French sheath. Two basic companies like Karl Storz and Olympus both make 26 French sheath. And when would you not use a 26 French sheath, and what are the new sheets which are available? I'll be telling you when I go along with my presentation. The common type of system which is used is Iglesias. It is a continuous flow system which is being used by all at present. Regarding the prostatic vascularity, the commonest thing is asked is what is the prostate artery? It's a branch of an inferior vesical artery, which in turn is a branch of an internal iliac artery. We all should know that because now the TAE, that is a transarterial embolization of a prostatic artery, is becoming very popular. And at least if someday in your institute they started, you should be knowing how to approach that to do an embolization of the prostatic artery in dire sequences. Regarding the urethral anatomy, urethra is never straight, as we all know. A lot of residents do the cystoscopies and stenting, and they should learn how to negotiate the urethra. And the approximately it is about 15 to 20 centimeters depending on the length of the penile urethra. And we have where does the sphincter come? What is the relevance of the veru, and how the prostate, the enlarged prostate looks like. Whenever they are doing a urethroscopy, they should get accustomed to that, and more they will do, the easier it becomes to do a TURP in a good quality TURP for them. Regarding the TURP table, this is a historical TURP tables in which they had a dedicated table for the TURP and an outlet which would not soil your OT and make a mess out of it. But these are no more used. This is the TURP drapes which we are using, which can cover the patient very nicely. A single drape will take care of everything. It will give you an access to for a DRE just in case if you want to do it. The penis is in front of you, and there is a channel which goes directly into the drain. And if this is not available, you can just connect a simple silicone tube to the outlet of the sheath, outer sheath, and which will go into the bucket and not soil your things. Regarding the position, this is very important. A lot of senior teachers who are fond of names would definitely ask you regarding the position. This is the wrong position on the left side. The right position has to be given along with they may ask you what sort of supports do you use. You should know about two. One is the Lloyd Davis support and the Mitchell slings, which are more commonly used in routine OTs. Coming to the technique of the section, what are the TURP methods? The commonest methods are the Barnes, Nesbitt, Alcock and Flocks, Mormar and Blandy, and two more have been added. I'll just talk about them. The most commonly practiced in India, at least what I'm aware of, is the Nesbitt and the Mormar technique, and which videos I'll just show you. The aim is to achieve a conical resection of the prostate. You always remember that it's like a cone, and this is how the fossa would look like at the end of a good, nice TURP. The part one of the technique of the TURP is the assessment of the meatus, the urethra and the prostate. You can't put a 26 French, scope directly into the urethra and do a TURP in a patient. You need to assess the meatus with a meatal calibrator or a simple 16 French cystoscope sheath if you have in the department. Otherwise, 19 French sheaths are always available. You can always negotiate that sheath and come to know how tight the urethra is, especially in the cases which are not catheterized in the patient. Why metal calibration? To do a metal dilatation to avoid submetal stenosis, which is the commonest complications post-TURP. So you use either a metal or the metal one or a plastic one, whatever you have in the department. You need to dilate the urethra because the urethra to place a 26 French sheath, you should have a good, nice dilated urethra. In case of pre-catheterized patient, you may or may not need that. But in catheterized patient, you may not. But a non-catheterized patient, you would always need either to do a otis versus dilatation. This is how the otis looks. If you're not if you don't have one in the department, I would request you to go to any of the stalls of the companies who are there in any of the conferences and see this instrument, use there itself, and you'll come to know what this instrument is. Because if any department has that, the examiner would definitely ask you about the otis, and why the otis is to be used is important to know. If you don't have that, male dilators are available in all urology departments, and you can use that. The otis is a procedure of choice because it gives a single cut and a good opening to place your sheaths inside. And if you don't have anything available, 11 French, the stab knife 11 number stab knife can be used with a single clean cut to open up the submeatal region, which is invariably a gripping thing and not allow the 26 French sheath to move in. Urethroscopy is the second step after the meatus has been negotiated. The second step is to do a good urethroscopy. Usually the question which is asked from the residents is, would you do a urethroscopy or would you not do a urethroscopy in a patient? Cystoscopy is a separate procedure. And usually the answer is no until there is hematuria, but urethroSCOPy as a first step towards TURP is mandatory. You can do it with a simple urethroSCOPE sheath, or with the, when you have placed the under obturator, you have placed the sheath inside, but at the level of the sphincter you should stop, and this is how you perform a nice urethroSCOPy. You go inside. This is the viru. Look at the type of the viru. The 5 type of virus have been explained in the literature. Go and read that. Get inside the bladder. Have a look at the bladder. This is an unedited video, and it does not take more than a minute to do that. These steps should not be missed. Look at the ureteric orifices. How far is it from the median lobe of the prostate, so as not to land up in trouble, because this trouble, if happens, then one is in a big trouble, because you have to either do open surgery or something, which is not acceptable in a TURP in today's era. So once you are coming back, look how far the sphincter is from the virumontanum, and this is the wobble sign. You can see the sphincter getting contracted there. And once you have done a nice clean urethroSCOPy without injuring the urethra, you can put the resectoscope sheath under a visual obturator. Always put under a visual obturator. This is the examiner, and if you have not seen a visual obturator in your department, you should always go to again in any of the conferences and see the visual obturator there itself. So the operative technique, initially I'll explain what is Nesbit's and Mormyer's. The Nesbit invariably starts at 12 o'clock position, then lateral lobes will be resected from the bottom, and the median lobe will be last to be resected. This is how Nesbit is being done. So if you see here, this is the way we have to do a Nesbit technique, and this is what we want to achieve is a cone here. Again, I'm doing a urethroSCOPy. Prior to starting the resection, this is the sphincteric area. I'm very sure where the virumontanum is. In this case, the prostate is proximal to the viru, not an issue. And there is no median lobe here. There are 2 lateral lobes. This is a good case. This is a very small one, but not much. So this is a very good case to do a Nesbit surgery. So I have not started. This is the Nesbit has to start at 12 o'clock, but I don't, we have just modified it because we don't do it. We keep the mucosa, a strip of mucosa there. There you can see the circular fibers coming after about a few cuts only. So you should be very, observant about that. And then you take it as a reference point to do the cutting of the remaining of the prostatic tissue. Here I'm demonstrating a monopolar TURP here. So once I've done on the one side, then I start on the opposite side. That is exactly at 11 o'clock position now. And again, after 2 or 3 cuts, you will be able to see the circular fibers of the bladder neck. And once they are seen, they'll let you know that what should be the depth of the prostatic resection here. Any hindrance in the vision should be taken care of then and there itself, so that there is not much of an issue there. So here we are doing it, and now you can see that the bladder is opened up nicely. So once we have done on one side and the other side, then we go down middle lobe, and then in the last we are doing the median lobe here. The important part is not to make rush. You just gently pull the working element so that you are not cutting it very fast. Fast cutting does not help. It does not increase the speed. It is invariably hemostatic also. So here we are doing anything which can hinder the process should be taken care of itself, so that it does not, you don't go deep there, as it can cause perforation or opening up of the sinuses, which is not a very good position to be in. So you should be very vigilant when you are doing these things. And once you have come to the capsule contraction, see here I'm going to see the capsule contraction here. So this is now the capsule has come. If I go beyond it, so I'm going to land up in trouble. So you should be very observant when you're doing a TURP. If you feel that the capsule has come, you just stop. It is always better to be under than over, because otherwise it can cause a lot of problem. And once the thin fibers are there, you don't, this is what you want to achieve. This is the apical lobe is left, and the apical lobe has to be done in the last. Very small and controlled cuts, so that you don't go very deep here and don't go beyond the viru here. So any point of this thing, you should always see where the viru is. So this is what you want to see at the end of it. And once you have removed the scope, this is a type of the stream you would like to see a patient voiding in a nice stream and hardly any color to the urine itself. Coming to the second most commonly performed technique in India is Mormyer's standard technique, introduced in 1981. This involves a resection of the middle lobe first, or the tissues lateral to the middle lobe, creating a space for the fluid to go in and out. And then you start the left or the right lobe, and then in the last, again, the apical tissue has to be in the last. So this is again a video of the same. Again, I am doing a urethroskopy first. This urethroskopy helps me to plan my procedure. So any procedure, surgical procedure should be planned. There is a groove. This is the median lobe there, sitting in the middle. So I'm starting at about 7 o'clock position. So there I go. So once I have started going there, my first aim is to see the circular fibers of the bladder. So again, I'm not pulling it very fast. I'm just pulling it very slowly here. You can see that. Hello. I'm in a meeting. I'll call you later. So sorry for the interruption. So this is how you start, and then you start towards the opposite side. This is about 5 o'clock position I have started. So now you can see the median lobe in between, and the two things on the side, which helps us to have a good flow of the urine. So once that has been done, so I've done the median lobe, and this is how a thing fossa should look at towards the end of the procedure. I've done the apical lobe, and this is nice cone which has been made. A few bleeders here and there, they usually don't make much of a difference, but this is how it looks like. When I come out, I'm proximal to the sphincter and proximal to the viru. So this gives me a good thing that my patient is going to pass urine nicely. So look at the stream of the urine. So Barnes method, it's not a very commonly performed method. Starts from the median lobe. Again, the lateral lobe will be resected from top to bottom. So the other techniques which have been described in literature, and as a resident you should know, is Alcock and Flock's method. It starts at 9 and 3 o'clock. Then depends on the situation or what sort of a vascularity you have encountered in a patient, and you can go from top to bottom or bottom to top on one side to the other side. This is the Blandy's technique. The identification of the middle lobe has been done first. It opens up for the fluid to go in and out, and then you can carry on as you are doing. The other techniques include Richard Notley method, in which the plan of resection after removing the middle lobe. Here also the middle lobe is taken care first, and this is probably to allow the fluid to go in and go out. And after removing the middle lobe, the operator starts in a clockwise manner. It goes from 7 o'clock from up and from down. So this is how it looks at the end. And Milner's technique has also been described. Again, in this case, only at 3 and 9 o'clock you are given up the resection, and then you go on to process. But the basic aim is to achieve a nice cone towards the end, so that the patient is able to void and there is no hindrance to widening of the patient. So again, to be revised, the TURP methods: Barnes, Nesbitt, Alcock and Flocks, Mormyers, Blandy's, Richard and Notley and Milner. But the most commonly which are performed is Nesbitt and Mormyer. What I would suggest to the resident is, whenever they are watching their consultant doing a TURP, they should ask what sort of technique he is doing, and in the exam stick to that, knowing what the other techniques are there in the literature. So it is not an excuse not to know what other techniques are, because you never know which you would like to do in given situation at a particular period of time. So these are the two which are more commonly performed. Again, coming to the thickness of the chips, somebody may ask you, it's a thick chip. Is when you start at the start of the procedure, you have to dig in and take out the chips, large chips. Why they are important is because in a large prostate, the time is everything. So this is the thick chip we have taken out from a patient who had a 80 grams prostate. And coming to the the extended cutting versus small single cuts. When do you do extended cutting? You do an extended cutting in a large prostate, and a small cuts when you are towards the apex of the prostate. So this is the two different chips in the same patient, and you can see the difference between the chips. When you're doing initially, if you have taken a large cut, the time spent in the patient is less. So hence the complications of the TURP. Invariably, whenever you are doing a TURP, what is the canoe form of cutting? I'll just show you that. This is how you achieve a good cone when you're doing a TURP in a patient. So just look at the movement of the hand. How do you get a good thick long chip of a prostate along with the formation of a canoe? So everything is fixed. Only what you're moving is the working element. You're not moving the sheath at all. And this not moving of the sheath is important. and you are just not cutting very fast, you just take your time and be slow when you are cutting that. Don't over or undercut. And the appearance of apical tissue, coming to the apical tissue cutting, it is very important, because apical tissue, if you have not done it, if you overdo it, the patient will be incontinent. If you underdo it, the patient will not be able to void. Regarding a retrograde cutting, should not be done by a novice. It is done only for smaller, smaller tags here and there. With the experience, yes, you can do it, but not as a beginner. Principally, this is how the cutting should be. It should be a segmental cutting if you're a beginner, and not take very long cuts if you're not able to take it. But it has to be a tangential method. If it is a large prostate, you need to plan the proximal, the middle, and then the apex accordingly. And you should watch your consultant doing a TURP, whomsoever you want to idolize. You just watch him doing again and again and again and again, because in your residency, you may not be able to do a lot of TURPs, but it is a matter of number. If you know the principle or a technique of doing a TURP, it's just a matter of numbers then and refinement, which comes with the time. No resident will be foolproof to do a good quality TURP. If you are lucky, but at least you should know how technique and how to approach the prostate. This is very important for a beginner. Regarding the technique, it is called as a predetermined start and the end point. Means you got to keep your sheath as a very stable position. You can't move your sheath. So in your mind, you need to understand this is the endoscopic view. So here the sheath is fixed, and you just moving the loop around. So you should know which is the predetermined start point. Like in this case, this is the starting point you have to do, and this is the predetermined end point. So my suggestion to all the residents is, when you have been allotted a case of TURP, and when you're just going to begin, in your mind you should register which is the predetermined start and end point. It may be a small cut, not an issue. It may be a long cut, not an issue, but you should not be moving the sheath, because if you move your sheath much, then you will be in trouble. Otherwise not. Bleeding, any cut will bleed. How do we, stop the bleeding? One question which is asked from the residents is, what is the transfusion rate? It is very low in today's era, because of improvement of the, you are able to see how your seniors have done it. The cauteries have improved. The quality of cameras have improved, and instruments have improved. So it's not, the transfusion rates are not high, but average blood loss is anywhere between 10 to 15 ml per gram of the tissue resected. You should remember that. And how to, identify the bleeding. The straightforward bleeders, as I showed in the things, can be, cauterized very easily. But problem happens if you're not able to do it. If you're not able to delineate a bleeder, you need to cut. You need to cut the tissue. Here it is in the third. You can see the tissue has been cut and the bleeder comes directly in front of you, and then you can, stop the bleeding. In special situations, the bleeding is coming towards the scope. How do you circumvent that? In this case, you advance the scope sheath beyond it and just move a few millimeters back. You see the bleeder, and you just coagulate and cauterize that. Have patience, it will get coagulated. The other rare situations is, if you're not able to see a bleeder, you can always put your finger in the rectum, lift up the prostatic tissue, see the bleeder, and do that. Or you can press at the level of the bladder neck, or just proximal to the bladder neck. If your scope is not reaching there, empty the bladder and push the bladder from above, and you'll be able to see the bleeder and do that easily. Sometimes there may be a bouncing bleeding, or called as ricochet bleeding. So you are looking somewhere else and the bleeding is coming from somewhere else. So again, be meticulous and see every area, and you will be able to find the bleeder. The point here is to have a patience and planning while resection. So you should not cut at one side, opposite side, then again come to one side and right and left and right and left. You finish up one side, attain hemostasis that side, and go to the opposite side, then you won't be in trouble. So really elevating the height, that too transiently, will help you in attaining what you want to attain. And you can take or temporarily you can take your transiently taken from 60 to 100 centimeters. This is the Badenoch's arteries, which is at 5 and 7 o'clock and 10 o'clock. I've never used this thing, because with the newer sort of cauteries, it is going to be of great help to us to not to get into trouble. But this is one of the techniques which have been described in literature. So you can coagulate them prior and then proceed with your resection. Special situations like sinus bleeding, don't waste time. The technique to, more time you spend, more confusion happens. And you can just put a balloon. In 1937, the Foleys, who first explained, had advised to put the balloon in the prostatic fossa, which is not the case to be done. What we have to do is, we have to take it inside the bladder and then pull the bladder, pull the catheter, and then the sinus bleeding would stop. The amount of the fluid to be filled in the balloon, this is the question which is asked, and it is generally recommended is 1 ml per gram of the resected tissue is the amount of the fluid we put. How I put my traction is I put my traction on the leg. You have to shape the leg nicely so that there are no hair on that, and then you fix the. Then you pull it around. You see the urine is absolutely clear. While you are pulling, it should not be too much of a pull. Then you fix. This is at the end of the procedure how I do it. But you can always fix at the abdomen because the pressure points of the urethra are taken care of. Anyways, the traction is not for long. Once the spinal or the regional anesthesia goes away, it always invariably gets loose. I've never seen a very good traction lasting for more than 6 to 8 hours. It is only for our thing, but this is one way of putting the traction. And once this is done, you just look at the free flow of the fluid. It should be whenever the catheter, it's your responsibility to see that the free fluid and there's no redness. If in between this gets red, that means there is some arterial spurter is there. It should be clear from once you have given a traction, and there should be a free flow of the fluid inside the thing. So if the point is that if while operating, the things have stopped, then you communicate with the staff. Sometimes they may have put a saline instead of glycine. Your loop would be broken. Invariably, we are reusing the cautery plates. You change that plate, check and recheck, and you should always have an extra, the things like a loop, extra loop with you, or the cautery plates with you if you're doing a monopolar TURP, so that not to end up in a messy situation. Check your loop. If your loop is not cutting properly, it may be either broken or sometimes like here, when you're closing the loop, this point has to be checked. If it is not completely coming inside the sheath, then it will not cut the tissue completely. So the tissue will hang at the end of it. And it should not be bent so much that it causes damage to your scope. So you have to be very particular about it. And you see the things before you have to proceed. The special situation point-in technique is a median lobe. If there's a large intravesical median lobe, if you are a beginner, then you should be very, very cautious how you are doing it. You have to lift the median lobe and then do it. And you have to keep yourself oriented to the prostatic tissue. If you are not, then you can easily land up in trouble by just cutting this. And what can happen is you can cause a ureteric injury. Remember at the back of your mind, if your consultant has not caused it, that does not mean that you will not cause it, because it is experience. A bladder perforation can happen while resecting a large median lobe. A subtrigonal perforation is not uncommon, and bleeding is, of course, that you can also manage. So large prostates, beware of incontinence. If the prostate is extending beyond the viru, it's a tricky situation. If you're working in an institute, do call your senior consultant to help you out and tell you when to stop. Otherwise, the patient would be incontinent and not very happy to be with. This is a picture when it is proximal to the viru. This is not an issue, but if it is going beyond the viru, then it is definitely an issue for you. Special situations, very large prostates. Sometimes people will ask you use of a suprapubic trocar. Can or cannot be used with the instrument at present. I have not used it for last 10 years, but for a resident point of view, you should know why to use a suprapubic trocar and when to use it. What is the average size of the prostate beyond which you want to use it. Academically, 80 grams and above, they have recommended the use of a suprapubic trocar. It facilitates the low pressure, takes the fluid away from you, the resection speed increases, and you can always say in the exam for the large prostate, if you don't have an access to a laser or know-how of a laser or an open surgery, you can always stage the procedure. For long urethras, short scope length, you can do a urethrotomy and go through the bulbar urethra. Rarely needed. In my 15 years of practice, I've never had the need of that. Take home message is, this is the uroflow which the patient has come to you, and this is the uroflow which you want the patient to have. And all the different techniques are there, but there is only one goal. Don't jump the steps. Plan your procedure on one or the other technique. Learn one, master one, don't experiment. Aim for segmental resection to achieve a cone. This is what you want to see at the end of it. Attain hemostasis first. If vision is not good, do not venture further. If you can't see, you can't do endourology procedure. That is a basic dictum. My teacher taught me, can't see, don't proceed. Hemostatic agents or traction is not an alternative to good hemostasis. Don't fall for that. Constant lubrication is a must. Give realistic expectation to the patient, and as all TURPs are not the same, and know your limitations. Thank you. Thank you for a patient hearing, and any questions I would be
Thank you,
there.
Rahul sir. We'll take some few comments from the experts and
Yeah.
then we'll take some question from the chat box. So expert comments, sir.
Yeah. Hi, Dr. Rahul.
Sir, good morning.
Good morning. Good morning. At the beginning, I should compliment you for providing this elaborative presentation about various aspects of TRP. Wonderfully explained. Very nice. As all of us urologists feel that TRP is the commonest procedure, but that never means it is the easiest. We got to learn it properly. And since this is a resident assembly, the beginners, they have to learn it properly. And I think you have covered all aspects, right from putting in the jelly, how to put in the scope, and how to understand. So we got to learn it in a way that we have a methodical, sequential resection we are doing, making a mental image that what we are doing as the resectionist, and having a good vision, a good flow, and able to control the bleeders. And what I would suggest the beginners that be very patient in learning and observing and mastering this technique. Maybe one of the techniques, as you described, the Barnes, the Nesbits, or Mormere, whatever they are familiar or they are comfortable with. And never force things. Like many times we have seen the beginners going subtrigonal, creating a subtrigonal track, and then things get mixed up, lot of bleeding, and then you have to stop. And one more thing that I would like to add, that like we say in the open surgery, that open chance is the first chance is the best chance. But in endoscopic surgery, there is always a second chance. If things don't go smooth, you can stop, you can do half the resection, can be completed next time. So you have to take the interest of the patient into consideration. That is of the paramount importance. And learn sequentially, methodically, and over a period of time, with experience, you can become a good resectionist and do a very good TRP. So that's all what I want to add. I think all other aspects you have nicely done a commendable job with this presentation. Thank you.
Hi, Dr. Rahul. First of all, I will congratulate you for very comprehensive talk, I think, and you covered all important things, but it is definitely a very important topic and very important procedure for our residents. So, like regarding techniques, the most important point, it should be always a systematic resection, as it is highlighted. So, the advantage with that is, like, if suppose in case if you are having any problem, first of all, we should at least we are clear with one lobe. So it might be possible you can give later on voiding trial to that patient. So one lobe is clear and you can switch over to second lobe then after maintaining. Another point you have highlighted, the technique regarding Mormore's technique, I personally feel I prefer that. So points in favor, like is already highlighted by Dr. Rahul, and I am re-emphasizing those points. Like this permits a free flow. Even median lobe is not enlarged. We clear bladder neck and 5 to 7 o'clock. So that makes little bit less vascular gland. So that is one point. So I personally prefer that. And then we can mark out distal limit key before starting my resection. Like just proximal to Veru, I just mark with this dithermy so that we can have. And as I was told with, like, not right now, but initially as used to be, as I was told my teachers, like, so for beginner, it is maybe important, like before what he used to say, he used to overemphasize before each resection, you should look into, you should come back and you should look Veru montanum. So that if you're going to create one incontinent patient in beginning of your care, that may be very hazardous for you. And I think you will be scared later on. So I think very well it is covered, and with those things, I think then it is important now. This case selection is also important. Before this procedure, I think I will suggest a properly selected case is also important. And then definitely TURP is still important technique and we should learn. And things has been changed. Now we are not able to see those TUR syndromes and bleeding, and that's definitely with good vision, and those things have been changed, improved a lot. Thank you.
There is a comment on the chat box whether what a non-conducting jelly versus conducting jelly. Dr. Rahul, any thought, comment?
Yeah, exactly. There's nothing, conducting jelly or non-conducting jelly is not an issue. Some people, this is the basic, is a xylocaine jelly we are using, which is very simple jelly. You have to put, the only thing is that the instrument and the urethra needs to be excellently lubricated. Now the jelly comes in two strengths. It comes as a 50 gram and it comes as a 30 grams. If it is a 50 grams, you use one, or if it's 30 grams, at least 2 to 3 jellies should be there, depending on the size of the prostate and time you're going to take. And the one of the work of the assistant is every after some time you have to put a jelly. There should never be a resistance when you're pulling the sheath in and out. Rather, the commenting on the conducting or a non-conducting jelly does not make a difference. Any jelly, it's basically a lubrication you have to use. If somebody wants to add, he can add to this thing.
I think it is preferable to use, earlier it used to be, it should be non-conducting, but it is better that a conducting jelly is used rather than a non-conducting one. Why? Because the tissues remain in one, as otherwise there would be areas where the tissue would be conducting and would be in directly contact with the metal. So there the chances of burn injuries would be higher. So if the entire sheath is in contact with the rest of the tissue through a conducting jelly, at least there would not be points where a higher temperature is going to be there and the tissue injury is likely to be less. But on practical terms, mostly it doesn't matter too much.
Matter much, because the only thing is that good lubrication should be here. Just one point I want to highlight for all the residents who are attending is that this is one of the surgery which doesn't get hyped in conferences and workshops. But this is the surgery, whosoever consultant, even today, even if somebody's senior consultant is doing a TURP, I would stand and watch and see his movements. You do that, and once it is your way of doing it, you will understand why what you have seen will surely help you.
Well, yes, one cannot highlight it more and emphasize it more, that it has to be the mental picture and anatomy of the prostate, which part is being dissected. It is not only the length of the cut, the depth of the cut, the depth at the bladder neck and at the virumontanum have to be kept small. Whereas in the middle part, when you are in the harvest phase of the resection, then you can take deep excavating and long cuts also, and take thicker cuts to reduce the resection time. Therefore, it is important that a systematic approach is followed, and the mental picture of both the bladder neck, virumontanum, as well as the prostatic capsule, that is kept in mind during each cut. So that's the crux of the entire procedure.
Yes, sir. Dr. Rahul, you have covered very well. One point, just a small point, that distance from the bladder neck to inspector at the base is longer than at 12 o'clock. So this should also be in a mind all time while cutting.
That is why after only 2 cuts or 3 cuts, you'll be able to see that the circular fibers. And once you see that circular fibers, you should then do it accordingly. So that comes with the experience. Absolutely.
Yeah. Thank you, everyone. Thank you, Rahul sir and the experts, for the excellent talk and session. I'll be moving on to the next session.
Thank you for having me.
That is the Journal Club, and we are presenting the EMBARK trial published in NEJM this time. And the presenter is Dr. Ankit Singh from AIIMS New Delhi. And the Journal Club is assessed by Dr. Narayan Shubham from BHU and Dr. Sharvagya Jain from RML Lucknow. And the expert for this are Dr. Anil Mandhani, Dr. Apul Goyal, Dr. Rajiv Kumar, and Dr. Shyam Priyadarshi. Dr. Ankit, you can share your screen. Thank you.
Girdhar, just a minute. I want to make a comment here.
Yeah.
For the experts of the previous session and Dr. Rahul, there are a lot of unanswered questions in the chat box. If somebody can please answer those queries, it would be good for the residents. Thank you.
Dr. Ankit, you can share your screen.
Yes. Hello.
Make it full screen, Dr.
Yes, yes. Sir, I am audible, sir?
Yes, you are audible.
Good morning, everyone. I'm going to present a Journal Club on EMBARK trial, which has been published this year in continuation of its previous draft in 2023, which consisted of improved survival with enzalutamide in biochemical recurrent prostate cancer. This original article was published in New England Journal of Medicine by Neil et al. Regarding the introduction and background of the study, before the publication of this article, the American Cancer Society already estimated 2.8 lakh new cases of prostate cancer and 34.7 thousand prostate cancer related death in 2023. Within 10 years after definitive therapy, approximately 20 to 50% of the patient will have biochemical disease recurrence. A rise in PSA level may be due to micrometastasis, regional localized disease, and distant disease. Level 1 clinical evidence regarding the treatment of biochemical recurrent prostate cancer is limited. The patient with PSA doubling time less than 9 months are considered to be at high risk for disease progression and increased risk of death from prostate cancer. In fact, the men with PSA doubling time having less than 3 months, the median survival is expected to be 6 years after biochemical recurrence. Evidence from prospective phase 3 clinical trial has shown that intensification of the treatment with next generation hormonal therapy such as enzalutamide not only prolonged image-based progression but also overall survival and delay the progression to castrate-resistant prostate cancer and maintaining the quality of life to the patient. In its previous draft, EMBARK trial, which was published in 2023, EMBARK trial revealed that metastatic free survival was significantly longer in combination therapy with enzalutamide with leuprolide as compared to leuprolide alone. And it was also significantly longer in monotherapy group in which they use enzalutamide alone. As well as PSA progression, first use of anti-neoplastic therapy, distant metastasis, and symptomatic progression, the combination group, as well as monotherapy group with enzalutamide alone did better than leuprolide alone. The 5-year median 5-year metastatic free survival was 87% in combination group, 80% in monotherapy group with enzalutamide, whereas only 71% in leuprolide group. Regarding the methodology, and they included the population which was non-metastatic patient having high risk prostate cancer, biochemical recurrent prostate cancer having PSA doubling time less than 9 months with no evidence of metastasis on conventional CT and MRI. Inclusion criteria consisted of all patient more than 18 years with histologically confirmed diagnosis of adenocarcinoma of the prostate. Patient had received previous therapy with curative intent in form of radical prostatectomy and radiotherapy. They had PSA doubling time less than 9 months and increasing PSA of more than 1 nanogram per ml after radical prostatectomy and 2 nanogram per ml after radiotherapy. Their serum testosterone must be more than 150 nanogram to rule out any castrate-resistant prostate cancer. All the patients were of ECOG 0 or ECOG 1 category. The exclusion criteria, any prior or present evidence of metastatic disease was exclusion criteria. Any prior use of cytotoxic therapy, chemotherapy, or any systemic biological therapy such as immunotherapy were included in exclusion criteria. Any history of seizure, they were ineligible for enzalutamide, and any prior hormonal therapy except the hormonal therapy which were used as neoadjuvant or adjuvant setting to treat prostate cancer less than 36 weeks of duration, and the last dose must not have been within 9 months of randomization. They can be included. During intervention on the combined therapy, which included enzalutamide as well as leuprolide, and monotherapy, which included only enzalutamide, were compared to leuprolide only group. The outcome consisted of primary endpoint, which was metastatic free survival between combination group enzalutamide plus leuprolide versus leuprolide only group. The secondary outcome were metastatic free survival between enzalutamide monotherapy versus leuprolide alone group. And other secondary outcome was overall survival, time to first use of new anti-neoplastic therapy, time for first symptomatic skeletal event, and progression-free survival. The first primary endpoint and first secondary endpoint was published in the first draft, which was in 2023. The rest were published in this year, 2025. A total of 1,068 patients with high-risk non-metastatic prostate cancer with rising PSA and having no previous cytotoxic chemotherapy or ADT were randomized in 1:1:1 group for combination therapy, monotherapy with enzalutamide alone, and leuprolide only therapy. A study population in combination group and leuprolide group were double-blinded, whereas enzalutamide monotherapy received open label without placebo. Dose of enzalutamide was 150 milligram per day orally, and leuprolide was 22.5 milligram, either given intramuscular or subcutaneous every 12 weeks. Serum PSA was quantified in their central laboratory, which was not provided to study site investigator or patients. Serum PSA was done throughout the study at baseline at the time of screening, 1, 25, 36, and 37 and 49 weeks, and then 3 monthly. In all the arms, the treatment and the PSA was assessed at 36 week, and if the PSA level was less than 0.2 nanogram per ml, the treatment was stopped in order to minimize the adverse effect. And when the PSA rises to 2 nanogram in previous radical prostatectomy patient, and 5 nanogram in previous radiotherapy patient, the treatment was started again. The treatment was stopped only once. The imaging study was conducted at every 6 months in form of CT and MRI. The results were analyzed on basis of 4 secondary endpoints, which was overall survival, first use of anti-neoplastic drug, first use of skeletal event, and progression-free survival. The first secondary endpoint was overall survival. Up to final analysis, total of 277 deaths occurred, 73 of which occurred in combination group, which consisted of enzalutamide with leuprolide. 93 occurred in monotherapy group with enzalutamide, and 111 occurred in leuprolide only group. The median follow-up was almost 94 months in all the group. The overall survival was significantly longer in combination group. In combination group, which was 8-year overall survival was 78.9% in combination group as compared to 69% in leuprolide group, which translated into hazard ratio of 0.6, which was significantly better in combination group than leuprolide only group. The 8-year overall survival in monotherapy group enzalutamide was 73.1%, which did not differ significantly than leuprolide only group. This is the Kaplan-Meier curve for comparing combination group with leuprolide only group. As we can see, the separation of two curve at almost 4 years in combination group with hazard ratio of 0.6, which was significantly improved in combination group as compared to leuprolide only group. And the below there is a Kaplan-Meier curve of monotherapy versus leuprolide only group, which did not translated into significant overall survival of monotherapy over leuprolide only group. This is hazard ratio of combination group as compared to leuprolide only on the left side, and monotherapy group as compared to leuprolide only on the right side. As we can see, the divided into different subgroup of the patients. As we can see on the right side, and the overall survival hazard ratio are non-significant for enzalutamide over leuprolide in any of the cases. In the left side on the combination group, the hazard ratio and overall survival was significant if the PSA doubling time was 3 to 6 months, patient age more than 65 years, patient ECOG performance of 0, patient non-resident of Europe, irrespective of Gleason score and PSA value, the overall survival was better in combination group over leuprolide group. Overall survival was also better in if prior radiation and prior prostatectomy was done, and it was better if no prior hormonal therapy was given. Moving on to the next secondary outcome, which was the first use of new anti-neoplastic therapy. Total of 82 events occur in combination group, 118 in monotherapy with enzalutamide group, and 170 in leuprolide only group, which translated in hazard ratio of combination group over leuprolide of 0.37 and hazard ratio in enzalutamide group over leuprolide of 0.57. Both were significant. Regarding the first symptomatic skeletal event, was defined as use of any surgery or any radiation to the bone for the subsidement of the symptom, any new onset fracture or spinal cord compression, any new addition of opiate therapy, and any new systemic agent used for bone. So total 16 first symptomatic skeletal event occur in combination group, 37 occurred in leuprolide group, and 19 occurred in monotherapy group. Hazard ratio of combination group and monotherapy group was 0.4 and 0.49 respectively over leuprolide group, which was significantly better. And the first two Kaplan-Meier curve on the left is for combination group and monotherapy group regarding the use of new anti-neoplastic therapy, both translated into significant improvement over leuprolide only. And the second is the development of first skeletal event after the use of combination over leuprolide and use of monotherapy over leuprolide. Both were significantly better than leuprolide. Both combination and monotherapy were significantly better than leuprolide. Regarding progression-free survival, total event occurred was 75 in combination group, 118 in leuprolide only group, 97 in monotherapy group with enzalutamide, which resulted in hazard ratio of 0.56 and 0.76 in combination group and monotherapy group with enzalutamide over leuprolide only group. They also assessed, apart from secondary endpoint, they also assessed safety and adverse event of enzalutamide in combination group as well as in monotherapy group. The median duration of treatment, excluding the period of suspension at 36 weeks, was 46.7 months. No new safety signal for risk was reported. In all the groups, approximately 98% of the patient developed adverse event, most common of which was hot flashes, which consisted of hot flashes and fatigue, which consisted of 30% in combination group and leuprolide group.
Ankit, you can wind up. Give the salient points of the article.
Okay, sir. Okay, sir. This is the safety and adverse event chart, in which the one point to be noted that all the arm were comparable, but the breast related side effect were more in monotherapy with enzalutamide group, be it gynecomastia, breast tenderness, or nipple pain. So, in discussion, it was the overall survival in EMBARK trial shows in the favor of combination group over leuprolide only group, whereas the overall survival was not significantly improved in monotherapy group with enzalutamide as compared to leuprolide only group. And this is in accordance of previous draft, which translated into better metastatic free survival in combination group. Although the enzalutamide did not show better overall survival, but it was better in comparison to leuprolide group in other secondary endpoint, which such as first use of primary antineoplastic therapy and first symptomatic skeletal event. So the survival benefit in the trial showed that no new safety signal of adverse event and adverse event profile of enzalutamide was comparable to that leuprolide only group. In the critical analysis of the study, it is randomized controlled strength of the studies consisted. It is randomized controlled trial with well-matched groups, and it was multi-center study conducted in 17 countries over 244 centers with large sample size. So the result is generalizable and can be accepted globally. The duration of the follow-up was also adequate, which was almost 8 years. They gave 8-year overall survival. Regarding the weakness of the study, the enzalutamide monotherapy group had open label design with no addition of placebo that might have potential for bias and casualty attribution and patient-related outcome. There was also underrepresentation of non-white population in this trial, less than 20%, and which has more risk for prostate cancer. And it was also a sponsored trial funded by pharma company, so there always a risk of bias in favor of newer treatment. Thank you, sir.
Thank you. Thank you, Ankit. And now I would like to take the comments from the residents about this trial. Dr. Narayan or Dr. Sarvagya?
Good morning, sir. Good morning to the esteemed panel. Sir, may I go first?
Yeah.
Sir, I have 1 or 2 points regarding EMBARK trial. One is, sir, we generally follow the EAU guidelines. And in EAU guidelines, sir, the time frame taken for a high-risk biochemical recurrence is different for post-radical prostatectomy and post-radiation. It's 1 year for post-radical prostatectomy and 18 months for post-radiation. But in EMBARK trial, we have generalized it for less than 9 months. So that is one point which I don't find very suitable. Another thing, Dr. Ankit has quoted ki 83% of the population was white. So whether the results can be extrapolated to Indian population, we don't know as of now. The third point, sir, when we get a high-risk biochemically recurrent patient, there might be some occult metastasis which we might miss if we are not getting a PSMA PET scan done. So I think they should have included a radionuclide scan in their study to rule out the possibility of the disease being metastatic. If they are calling the study a completely non-metastatic castrate-sensitive prostate cancer. And sir, another thing is, if they have taken 9 months as the benchmark for high risk biochemically recurrent cases, they might be including very aggressive prostate cancer, and so that metastasis free survival curve will definitely show a earlier suppression as compared to the EAU standards.
Any comment from Sarvagya? Sarvagya? I think we can take the comments from the experts. Apul sir, Vandani sir, Rajiv sir.
Yeah, okay. Apul and Anil, do you want to go first, Shivam? Or
Okay.
can I just summarize?
Yeah,
Yeah, Apul, you want to go first?
Yeah, hi, good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Okay, so very well presented, Ankit, and good comments from the other resident also. So he highlighted actually that PSMA PET CT was not done actually. So, but the authors have done bone scan actually. At that time, PSMA PET CT was not standard of care. So, what they have done is done CT, MRI, and bone scan. So it's they have whatever method they had at that time they have done to rule out metastatic disease.
Right, sir.
So that was one point, and it's a very robust study.
Okay.
So and I think it's a sort of a landmark study also because it tells us about this population, which is not uncommon, and BCR is a common scenario, and the guidelines are still evolving, and we really do not know what is the best way to manage these patients. So I think this study addresses a very important area, and as it's mostly it's a some points were there, for example PSMA PET CT and white population. So those limitations I think are not that big. So I think overall a good study and very well presented.
Yeah.
Anil, do you want to say something? Yes, Anil, go ahead.
Okay, yeah, thank you for presenting that study. But you see, if you read or follow one study, the main question comes whether you will follow it or not. I would not like to follow it. Why? First thing is, as he rightly said, PSMA PET scan is not done. So if I do radical prostatectomy with the intention of cure, and if there is a recurrence, why not I carry on that intention? Why should I label it as metastatic disease and treat it like metastatic disease? So if I do that, why didn't I do to begin with when I did radical prostatectomy? So if PSA is rising, I would let that rise until it rises to 1. When PSMA PET becomes positive, then only I would still I would treat the patient with radical thought, intent of radical treatment, and I would prefer radiation. This is, of course, after radical prostatectomy. So I don't think I would change my practice. The second flaw is, this is a very important trial for residents to understand HR. So hazard risk, most of us, again, I repeat, misinterpret, because if you come to HR of death, which is around 0.42, if you compare leuprolide versus leuprolide plus enzalutamide, the HR of 0.42 looks good. It looks in a way that there is a 15% improvement in survival, which is not so. Now, in the same article, if you look at the death rate with combination, it is around 6%, and with solo therapy, it's around 2%. So, practically, there is a difference of 4% when you talk about the death caused by the disease, which is not that significant. And the third question I would ask maybe the panel and Rajiv, what if we had started enzalutamide after initially starting LHRH? I mean, you see, there is no harm in this trial, so we cannot question the trial. But the general question is, what if we start enzalutamide once PSA starts rising again, thinking that this is a metastatic disease, and we are not going with the thought of treating it as a localized disease with radical treatment. So that's what I wanted to contribute.
Thanks, Anil. Shivam, you want to come in?
Thank you. Thank you. First of all, sorry for being late joining. I could just hear the last portion of that. But I think, yes, this trial is okay, good. But because one of the, I think the major limitation being there's a sponsored trial. So we can't, I think this needs to be validated by some institutional study or multicentric study, unless we take this as kind of a recommendation. And I think that was a valid point that we need to have PSMA PET CT before we actually decide whether this is a metastatic disease or not. And this probably was a kind of good new study. It's the latest study. I don't think it was an old study. What do you say?
Sir,
Because
it
this
began in 2014, sir.
Acha, it began in, but it's going to be
2014.
published now. Okay,
Yeah, yeah.
2025. Okay, fine. Yeah. So, but at that time also PSMA PET was quite available. So, but anyway, I think these were my comments. Thank you, Rajiv. You can go ahead.
Thanks. Thank you, everyone. So I'll give you a summary of what I think happened and what should be happening. First, I think the study was very well conducted. There is no doubts about how the study was conducted. PSMA PET was not authorized for use in 2014. PSMA PET was not standard of care. Therefore, using PSMA PET at that point of time and inclusion in the study is not really relevant. It couldn't have been done. Many of the centers are in the US and even in Europe at that point of time where PSMA PET was not standard. So PSMA PET could not have been included. The second point was about why did they take 9 years as biochemical recurrence versus 1 year and 18 months? It actually means the disease is actually more aggressive. If the PSA doubling time is only 9 months, it is certainly less than 1 year and it is certainly less than 1.5 years. So any patient who's even qualifying by a stricter criteria would qualify by the lax criteria also. So if you had said 1 year PSA doubling time, here it's only 9 months. So he would anyway qualify. So it doesn't matter.
Just one question on this, sir. Wouldn't it improve the stats which are shown in the study if we take
You're not looking at improving stats. You're talking about whether the patient is high risk biochemical recurrence or not. You quoted data for EAU saying biochemical recurrence doubling time of less than 1 year is considered as high risk. Here it is even less than 9 months. It's even more stringent. Anybody who's less than 9 months is anyways less than 1 year. So these patients would qualify by the EAU criteria for both radical prostatectomy and for radiation. So even if you take the criteria you're suggesting, they would still qualify. It's a more stringent criteria. So it doesn't matter. Third question that Shivam raised and which Ravi has pointed out in the chat box, all these trials will always be pharma sponsored. There is no government, there is no institution which can afford to sponsor these trials. These are all company made molecules. Therefore, they will always be pharma sponsored. Yes, that comes with a conflict of interest. Therefore, you have to be careful of what has been written and how it's been written. But if you read the very first paragraph of or the very first page of the trial, the authors have actually addressed this point very clearly. What did they have access to? Who did the statistics? Who did not do the analysis? And therefore, while not ideal, you cannot get a better way of doing these trials. No other government is going to spend a few $1 million on getting these trials done. So unfortunately, while not ideal, this is the only way such trials will get done. Now let's come to the actual aspects of the study and the trial results. And let me ask the two residents who were analyzing, okay, only one is here, the second one didn't join in. What is the secondary endpoint? What do you mean by what is the difference between a primary endpoint and a secondary endpoint? What is the value of this?
Primary endpoint was metastasis-free survival initially, and in the NEJM 2025 article, they have included the overall survival also.
No. What is the difference? I understand which one was primary, which one was secondary. Why is it important to call something primary and call something secondary? Why do you call them like that?
We are more focused on the primary endpoint.
What does focus mean? Define it in scientific language.
Yeah, it's so.
What do you mean by
Study population.
By secondary endpoint in scientific language value terms. So the value is the sample size or the endpoints are always based on the primary endpoint. What is the primary point which you're assessing? That is used for sample size calculations. Therefore, when you do a secondary endpoint analysis, you may not have enough sample to assess the validity of the study. Therefore, you normally do not do secondary endpoint analysis with an adequate alpha. Alpha is the ability to rule out incorrectly reject the null hypothesis. However, in this paper, they've actually adjusted for the alpha. Alpha is the error you make. When you say there is actually no difference, but you make a difference and saying there is a difference, that means for pharma trials, you have to be very careful. You can't make alpha errors. And when you do a secondary endpoint analysis, you have a very high risk of making an alpha error. The second paper, if you read it carefully, the very first thing they state is we have adjusted for the alpha errors. That's a very important point when you're analyzing the methodology of this paper, that they've actually taken care of it. And therefore, the statistical difference is statistics. And again, I come back to Anil's point, which is very relevant. What he's saying is the difference between absolute risk reduction versus relative risk reduction. Relative risk reduction would mean there is a 50% reduction in death by this drug. Sounds brilliant. But the absolute risk reduction is only 4 people died in control arm and only 2 people died in the drug arm. So although the relative risk reduction is 50%, the absolute risk reduction is only 2 people, maybe out of 1,000 people. Therefore, you have to assess the actual value of what the difference is.
Right.
Nonetheless, putting all of this aside, the bottom line is the only thing which concerns me about the study is that it is possible some of these patients actually had metastasis. Again, something which Anil brought up very clearly. If you'd actually done the PSMA PET, some of these whom you're suspecting as having local recurrence may actually have been metastatic. We know that a doublet therapy today is standard of care for hormone-sensitive metastatic prostate cancer. It's quite possible some of these patients are actually hormone-sensitive metastatic prostate cancer, not M0CSPC. Therefore, the data here is contaminated. And then the second question that Anil said is again very valid, and I agree with 100%. We still don't have data to say that starting it immediately when PSA is 1 is as good as starting it when they actually develop bone mets or metastasis. There is some data to say starting hormone deprivation early is better in overall survival than starting it when mets appear. There is some data to support it. But you have to pair off that data with how much better. Let's say we waited. Let's say we wait till they actually develop mets. Not all will develop mets. Even among those who have BCR, not all will develop mets. About 50 to 70% will develop mets. And let's say we gave them the drug then. Would the outcomes have been any different? So that is the only other question. And I'm sure there are trials which will address it. But otherwise, the way trials go and the way trials are conducted, I think it's a well-conducted trial. It's a well-done trial. Whether we believe in it, whether we decide to use it for our patients is a different matter. But otherwise, it's design-wise, I think it's a perfectly okay trial.
Right.
All right. Thanks, Girdhar.
Yeah, thank you so much, sir, for this in-depth analysis, and thank
you, sir.
thank you all the experts for this expert comments. And we'll quickly move on to the next session, that is the imaging in urology, and that will be presented by Dr. Tarvinder. He is an assistant professor of radiology at PGI Chandigarh, and I request him to be crisp in presenting this talk, and he can show his slides. And the experts for this talks are Dr. Anup Kumar, Dr. Brashbanu Nayak, and Dr. Pratap. Dr. Tarvinder, please.
Yes, sir. Am I audible, sir?
Yeah, you are audible. You can share your screen, Dr.
I'm
Tarvinder.
sharing my screen. Is my screen visible?
Not yet.
Just a second. Is it visible now?
No, not yet. Share your screen.
Okay.
You must be co-host, I guess. So you should be able to present.
Just a second. I'll have to quit and then re-log in.
What we can do, Dr. Tarvinder, we can take the talk from Dr. Anuj first.
Okay,
and
okay, sir. That can.
But you can sort out your glitch.
Okay.
We'll be taking the drug spotlight first, and I request Dr. Anuj Sharma, is assistant professor of urology at PGI Chandigarh. Will be taking on medical therapies or BPH. And the experts for this talk are Dr. Hemant Goyal, Dr. Ishwar, and Dr. Yashasvi Singh. Dr. Anuj, can you please present your slides? Dr. Anuj?
Good morning. Good morning, sir. Am I audible?
Yes, you are audible. Share your screen and
Yes, sir. Yes, sir.
switch on your camera. Yeah. Present your slides.
Yes. So can I get the rights to share the screen? Yeah, this.
I think Anuj, you are the co-host. You should be able to. Yeah.
Yes, sir. So is my screen visible?
Yeah. Now it's visible. Yeah. Go ahead.
Oh. So good morning, everyone. I would be talking about the section on drug spotlight, which has the medical therapies for the BPH, a short review of the pharmacokinetics, pharmacodynamics, drug interaction, as well as the prescribing information and side effects. So considering that this presentation is focusing upon the residents and we need to cover the basic exam going questions and also what we routinely see in the OPD. So the various medical therapies include the alpha blockers, and most of my talk would be predominantly based on the alpha blockers in the management of BPH. And I would be touching upon the anticholinergics, the beta adrenergics, agonists, and the 5-alpha reductase inhibitors. Then there are phosphodiesterase type 5 inhibitors also. So we'll be talking about the various monotherapies as well as the combinations of all these drugs, predominantly the alpha blockers in combination with the various anticholinergics or the beta 3 agonists or the 5-alpha reductase inhibitors and others. So as we can see from this diagram, which is from the Campbell itself, the bladder neck as well as the prostate has all these various receptors. So talking about the receptors, the alpha-1 receptors, which are the adrenergic receptors, we have alpha-1A that is predominantly present in the prostatic stroma, the prostatic capsule, urethra, bladder base, and the neck. Then we have the 1B receptors, which are mostly present in the vascular smooth muscles, and the 1D receptors. These are predominantly present in the prostatic stroma and the detrusor muscle fibers. Subsequently, we would be touching upon the two aspects, what are the static as well as the dynamic components of obstruction. So a very careful mention is that the alpha-1D receptors are mostly the ones which are related to the static component, and the alpha-1A, which act on the smooth muscles, are the ones which are related with the dynamic component. So as we can see that in the alpha blockers, the classification is basically on the selective as well as the broad-based alpha blockers. So the dynamic component focuses on the smooth muscles and helps in reducing the sympathetic tone and of the prostatic urethra. Whereas the static component is the alpha-1D, which is the detrusor muscle relaxation and also acts on the afferent nerve endings and the glandular component. Amongst the various drugs, the non-selective ones are the phenoxybenzamine, whereas the prazosin and alfuzosin are the ones which are the older ones. And now the subselective or the uroselective ones are the tamsulosin, the silodosin, the alfuzosin, and the naftopidil. So talking about the first and the second generation alpha blockers are the prazosin, the terazosin, and doxazosin. So these drugs were having a primary limitation of having various side effects because they had a broad group of receptor blockage. So it included tiredness, dizziness, impaired ejaculation, nasal stuffiness, and congestion. In prazosin, it was a short-acting drug, so multiple dosages were required daily, whereas a first dose effect, which always needed titration, was the one which was happening with the terazo and the doxazosin. Talking about naftopidil, it had a more selective action on the alpha-1D. So I mentioned that the alpha-1D were the ones which act more on the static component. So it has 3 times more affinity. And it is proposed to be involved in detrusor overactivity too and inhibitory effect on the C fiber afferents. The ideal dose is around 50 to 75 milligrams and has a considerably lower incidence of sexual dysfunction, which I will be discussing about the other drugs in subsequent slides. Most of the data and the studies of naftopidil were done in Japan. So this drug is not very common or popular among the Western, especially the American and the European subsets. So the most commonly used alpha blockers which we have are the alfuzosin, tamsulosin, and silodosin, as we very well know in our OPDs. Alfuzosin initially was a 5 milligram dose, then a subsequent sustained release formulation of a 10 milligram dose has come into our clinical practice. And these are the highly selective ones. We only need a daily dosing. There is no first dose effect, so hence no titration, and it has a lesser side effect profile. So seeing the various pharmacodynamics and pharmacokinetics, the important thing to note is that in silodosin, it has a more selective alpha 1A compared to alpha 1B. So it has a more uroselective action. The Tmax is only 1.36 hours. So we should understand that silodosin has the fastest onset of action. So if we are asked about which drug has the fastest onset, the answer would be silodosin. Regarding alfuzosin, from this whole table, the important thing is its excretion. So its excretion in the bile is up to 69%. So a very important point is that in cases where hepatic dysfunction or in patients who are having chronic liver disease, alfuzosin has to be taken with a pinch of salt, and you have to carefully see all those comorbidities. Regarding the tamsulosin, again, it's a fasting state. It is absorbed almost 90%, and the food delays the absorption by 30%. So it should rather be taken 30 minutes. We should fix a meal and take 30 minutes after that meal. We usually take in the night so that the chances of any kind of hypotension or dizziness and other symptoms which are commonly present with alpha blockers are more circumvented during the sleep time. Again, tamsulosin undergoes the metabolism by both the CYP2D6 and 3A4. 3A4, which we know is more related with the ketoconazoles, and 2D6 with the various antibiotics. 70% is excreted in urine and 10% as parent drug, 20% in the stools. No dose modification is needed in mild to moderate, but yes, in severe hepatic and ESRD patients, we have to alter the doses. Regarding alfuzosin, it is a CYP3A4 mostly metabolized by the liver and is contraindicated in moderate to severe hepatic dysfunction. But even in patients who are Child-Pugh class A or mild hepatic dysfunction, this drug has to be taken with caution. And also in the patients who have a creatinine clearance of less than 30 milliliters per minute. Regarding silodosin, as I had discussed, it has a faster onset of action. It also has various cytokine and UDP glucuronidase transferase activity inhibition. So it is contraindicated again in patients with only severe and renal dysfunctions. In patients with moderate renal dysfunction, we can either switch them to tamsulosin or do a dose reduction of 4 milligrams. So in CYP3A4 inhibitors with the ketoconazole and azithromycin, it has a cytochrome P450 drug interaction, whereas the various antipsychotic drugs, including paroxetine and terbinafine, the antifungals, it has a CYP2D6 inhibitor interaction. Again, with PDE5 inhibitors, as I would also be covering later in terms of their role as LUTS drugs, both in mono and combination therapy, we have to be very careful that it can cause symptomatic hypotension, especially in elderly age groups where the reflexes or the blood pressure mechanisms are a bit delayed or they are a bit more rigid compared to the younger ones. Of course, all these alpha blockers do have their hypersensitivity, so we should be cautious in patients who have shown such kind of reactions. So mostly the antihypertensives which we have, including nifedipine, atenolol, enalapril, digoxin, and furosemide, they don't need any kind of dose modifications. In terms of alfuzosin, it again has CYP3A4 inhibitors, including ketoconazole, itraconazole, and ritonavir. Moderate activity seen with CYP3A4 inhibitors like diltiazem. With HCV drugs also, and along with concomitant liver dysfunction, these drugs have to be taken into consideration. We should avoid. And also, again, hypersensitivity cases, we need to avoid these drugs. In silodosin, apart from the CYP3A4, we have a cyclosporin. So in these patients, the plasma concentration of silodosin increases rapidly. And also in these patients, symptomatic hypotension can occur when used with PDE5 inhibitors. So before prescribing, the information we have to keep in mind is including the detailed history. We have to have our scoring systems. We have to see whether it's a voiding or a storage predominant symptoms and associated comorbidities of CKD and CLD, any drug history, sexual functions, all have to be taken carefully. The basic investigations we have are, again, the ultrasound to rule out any hydronephrosis, the size of the prostate, serum PSA, and a uroflowmetry. So alpha blockers, as I mentioned before also, a 30-minute following a meal should be an ideal time. A single dose should be decided to be taken every single day on the same time. And the drugs dosages are as seen for tamsulosin, alfuzosin, and silodosin. So a short recap of the various prescriptions. Can we prescribe them with antihypertensives? Yes, it's safe. In terms of the pregnancy, there is no documented animal studies having teratogenic effects, but yeah, we should avoid in these patients. In pediatric age group, considering that not many studies have been taking place, so it's not recommended. In elderly, for more than 75 years, there is no need to modify doses for tamsulosin and silodosin. But yes, for alfuzosin, the drug in concentration increases, so subsequently the dose modification needs to be done. In patients having cardiovascular profile, in the patients who are at risk of a cardiovascular events, silodosin is the preferred drug. Regarding sexual dysfunction, the important thing is that all these alpha blockers, because they improve the LUTs and they improve the smooth muscle blood flow, they can actually be productive, or they can actually have a good effect on the sexual functions. But in terms of the retrograde ejaculation or the an ejaculation can be a serious side effects which patients can have. So silodosin is the one which has the maximum incidence of an ejaculation, though in the various studies it hasn't been reported well to be a bothersome, but alfuzosin is the drug which is most preferred in these. So again, coming on to the side effects, we have the various side effects of tamsulosin, the silodosin and alfuzosin. In tamsulosin, dizziness is one which has the maximum incidence, whereas for silodosin, as we know, that retrograde ejaculation is the one which is the most commonly reported, along with thirst, loose stools, dizziness, orthostatic hypotension, and also ejaculatory disorders leading to discontinuation of the study. One very important thing which our ophthalmology colleagues have always reported is the floppy iris syndrome, which typically occurs during a cataract surgery. So the triad of a floppy iris syndrome is the iris tends to prolapse through corneal or limbal incisions. A flaccid iris stroma undulates and billows during the surgery, and a progressive intraoperative meiosis occurs. It can occur anytime after starting of the alpha blocker therapy and is described more with tamsulosin. We should kind of discontinue 4 to 7 days prior to the surgery, although the iris floppy syndrome has occurred in patients even after years altogether when this has been discontinued. And alternatively, a non-selective alpha blocker can be considered. So apart from BPH, the other things in which we are giving alpha blockers is in patients who are having any events related to LUTS. So in patients with acute urinary retention, in successful TWOC, alpha blockers have a role in terms of premature ejaculation, nocturia, overactive bladder symptoms, post-brachytherapy, preventing post-operative infections, and the urinary stones. In terms of improvement in sexual function, the possible mechanism by which alfuzosin acts is improvement in the quality of life, as I discussed before. Smooth flow in smooth muscle relaxation, as well as increased flow of urine. Along with that, direct effects of the blockade of alpha adrenergic receptors, including transduction pathways on the erectile function. Limited effect on alpha-1A receptors that induce a decrease in the volume of ejaculate by relaxation of bladder neck, or reducing the seminal vesicle contraction and sperm progression has also been seen. So this has been a recap of the various drugs which come under the alpha blocker category. Let's have us, few details about the other drugs. So we have what is known as the 5 alpha reductase inhibitors. So this is a table of the various hormonal manipulation drugs that we have in the market. But important to note is the finasteride and the dutasteride. So the receptors are basically of type 1 and type 2. The finasteride is acting selectively on the type 2, whereas the dutasteride is acting on both the type 1 and the type 2 receptors, and hence have a better profile in terms of blocking the dihydrotestosterone hormone. So the dihydrotestosterone is the one which works on the static component. So it works on the prostatic stroma, and the typical epithelial to mesenchymal transformation is inhibited. So the role is in a longer way. So you cannot expect the 5 alpha reductase inhibitors to have an instantaneous effect. The role or their effect will be seen from almost 6 to 12 months. So in the various studies that we have seen, it takes almost 6 to 12 months to treat of the treatment to see the effect. And in most of these studies, the very landmark studies included the PLES, the MTOPS, the COMBAT. The PLES and the MTOPS were focusing on the finasteride as combination therapy. So almost 18 to 28% of size reduction, along with 50% decrease in the circulating PSA levels is seen on a longer term. The finasteride is typically used in glands above 40 ml. It has a good and a significant role. Whereas for dutasteride, even in the ballpark of a 30 or a 40 ml prostate, also you can use these drugs. So the side effects, as we know from what it inhibits, the dihydrotestosterone, is that it reduces libido. Patients report erectile dysfunctions. And it also has a less frequent role in retrograde ejaculation and decreased semen volume. Many patients, they complain of pain in the chest area and gynecomastia in 1 to 2%. There had been predilections and studies focusing whether these patients do have a flare in the diabetes mellitus or depression, but in most of the studies, it couldn't get into a significant level. Another thing which was seen as a concern was regarding prostate cancer, whether it reduces the incidence or not. So the PROTECT trial and the other various landmark trials, they have seen that with the use of finasteride and dutasteride, it doesn't really provide that protection against the prostate cancer. And again, we have to see the PSA all values also, keeping in mind that these alpha reductase inhibitors are going on, especially the longer when the patients are taking it for more than 1 or even 2 or 4 years interval. So as what we have in the current EAU guidelines, use 5 alpha reductase inhibitors for men who have moderate to severe LUTS and an increased risk of disease progression in patients with prostate volume of more than 40 ml. Regarding the combination, again, 6 to 12 months is not a good time to see all the results. Longer term studies, which have a mean value of 2 to 4 years, including the MTOPS and COMBAT, they had showed that the combination treatment was superior than the monotherapy. So it had best of both the things. The best from the alpha blocker came in terms of the increased peak flow rates and amelioration of the LUTS symptoms, whereas the good thing coming from 5 alpha reductase inhibitor was a sequential reduction in the size of the sequential reduction in prostate size, leading to lesser risk of urinary retention and lesser need for surgery, seen both in the PLES and the COMBAT study. So after 5 alpha reductase, let's jump onto the anticholinergics and the beta-3 agonists. So as we mentioned while during evaluation, we have to see the IPSS scoring. So in the patients who have more of a predominant storage symptoms, that means the frequency, urgency, or nocturia, they are the ones which are bothering the patient more compared to the voiding symptoms. In those patients, a role of anticholinergics or beta-3 agonists can come into a picture. So the various drugs of antimuscarinics initially were oxybutynin, tolterodine, and propivarin. So they were broad selective drugs. Now newer vesicoselective drugs selectively inhibiting M3 receptors, including solifenacin, darifenacin, trospium, and fesoterodine, which is another analog or a further metabolite of tolterodine. In beta-3 agonists, we have mirabegron, and now we have a new drug, which is a vibegron, which has a better drug interaction, and its more effect on blood pressures is seen lesser compared to that of a mirabegron. So, I mean, these are the various combination therapies, and of late, as we all know, they have flooded into our OPDs, and we have various combinations and drugs of different dosages that we are using. So it is very important both for your exam as well as for your OPD practice to actually know which subset of patients require monotherapy, and when you have to think that, yes, now is the time that you need to upscale and share and have combination therapies for your patients. So coming to the guidelines, we should offer antimuscarinic and alpha blockers for storage predominant LUTs, and a beta-3 agonist is always an acceptable alternative. You always need to check for the PVR, and a borderline value of more than 150 ml can be kept in mind. For the anticholinergics, again, a cognitive risk enhancement has to be seen in patients who are elderly. Again, efficacy of the antimuscarinic monotherapy, it improves the urgency and other storage predominant symptoms, and best responders are the ones who have a lower baseline PVR. AUR is uncommon when the PVR is less than 150 ml. We can add antimuscarinic to alpha blockage So solifenacin and tamsulosin or tolterodine or tamsulosin, they do improve the storage symptoms compared to a monotherapy, and benefits are modest but clinically meaningful in selected patients. The beta-3 agonists in men reduces micturition and urgency in patients having small to moderate LUTS. The retention is uncommon and is a useful alternative when anticholinergics, adverse effects or cognitive risks, which are more common in antimuscarinics, are happening. So in terms of head-to-head combination, solifenacin plus mirabegron, so if we combine both the bladder relaxants, can do outperform better than either alone for persistent symptoms of storage LUTS. But the tolerability is acceptable with careful patient selection and monitoring. We should consider the combination when monotherapy benefits from the plateaus with all the synergy trials. So regarding the safety, with antimuscarinics, the AUR is always a concern which can happen. So always start or continue if PVR is less than 150 and always reassess within 2 to 3 months. Oxybutynin is associated with memory impairment. It is a good drug for the pediatric age group, but still for the adults, we have better vesicoselective agents. And in terms of trospium, it's a quaternary compound and has a lesser BBB for the blood-brain barrier penetration and can be used in those cases. With mirabegron, the retention is always uncommon again with 1 to 2%, and we should always continue checking for the PVR. No anticholinergic cognitive burden is there, so that is an advantage. But a small subgroup of patients with increased BP and a cardiovascular risk patients, in those mirabegron needs to be taken with a caution. For those drugs, we have vibegron, which has no CYP2D6 interaction, and it suggests BP neutrality. So the dose and the monitoring for all these anti-muscarinics and beta-3 agonists, solifenacin can be from the dose of 5 to 10 milligrams. Darifenacin is 7.5 to 15, which is M3 selective and favorable in patients having cognitive dysfunctions. Physotierodine is again an analog, and 4 to 8 milligram is the dose. Trospium comes in 20 milligram BD or a 60 milligram OD extended release. Tolterodine is 4 milligrams. Mirabegron, as we all know, is 25 and 50, while vibegron can be given as a single dose of 75 milligram OD. So again, a practical algorithm is treat first the outlet. So always start with an alpha blocker. You can add if 5-alpha reductase if suppose the gland is a bigger gland. If the patient on subsequent intervals is having a storage persistent symptoms, then you go ahead with a beta-3 agonist if there is a low cognitive burden. But if the cost and the coverage or prior beta-3 failure is there, then add an antimuscarinic. Escalate to combination if partial response is there, and always monitor these patients in terms of the side effects, including blood pressure monitoring as well as the PVR. So as we discussed before also, the evidence is in those patients who are having storage predominant symptoms, and a combination can always be better than a monotherapy if the patient is not improving in both the categories. Then coming on to the other drugs, the 5-phosphodiesterase 5 inhibitor. So as we can see from the flow chart, again taken from the Campbell, it acts through various mechanisms. So it increases the local blood supply, local oxygen perfusion, it decreases the afferent nerve activity, intraprostatic inflammation is decreased, and prostatic stromal cells proliferation is decreased, and also the smooth muscle contraction is inhibited. So it acts both, as I mentioned before, on the static as well as the dynamic components. So a 5 milligram tadalafil, the studies are limited in terms of a significant more than 1 year data, but it does improve both the erectile function scores as well as the IPSS, but not a significant increase in Qmax has been seen. So a single fixed dose combination of 0.2 to 0.4 milligram tamsulosin with 5 milligram tadalafil has been seen to have a significant impact on IPSS. But again, as mentioned before, since both alpha blockers and phosphodiesterase 5 inhibitors have a vasodilatory effect, so this has to be seen with caution. Always start with the alpha blocker and then come with the lowest possible dose of tadalafil, which is 2.5 milligrams. And then subsequently, you can increase keeping in mind the various side effect profiles of the drug and the patient symptoms. Contraindication includes various cardiac diseases, patients who are already on nitrates, or patient who's having a myocardial infarction within the last 90 days, as well as patient with unstable angina and heart failure patients with NYHM equal to or more than 2. Leaving the alpha blocker aside, can we have a PD5 inhibitor and a 5-alpha reductase inhibitor combination? So yes, there was one study, single RCT, which was there, and it showed that there was a higher improvement in IPSS compared to only finasteride when given alone. And yes, this combination of finasteride plus tadalafil 5 milligram has been FDA approved since 2021, and we are yet to see the drugs coming into our Indian market. So this was basically a whole review of the various drugs that we are using in BPH, more focusing on the 5-alpha blockers and the other group of drugs. A very small mention is on the phytotherapy. I mean, this is something which not my books, but some of my patients, they kind of teach us what they are using and what various other drugs or various other jadi booties or phytoremedies they are using. So amongst the literature, the hexane extracted Sironia repens, it does have 1 or 2 studies along with the combination with psilocybin, but again, they are weak recommendation drugs studies, and we need to inform the patient the magnitude of efficacy, which can be modest. And I could get few of the preparations or formulations which are present in our Indian market. Again, I need to be, I mean, other clinicians and urologists might have a say on their own experiences about these drugs, but just to complete the whole gamut of various drugs for BPH, I put this in my presentation. So thank you very much.
Thank you for an in-depth talk, and I would like to take few comments from the experts, Dr. Hemant.
Yeah, thank you, sir. Thank you, Dr. Girdhar, and an excellent talk by Dr. Anuj. I like to ask 1 or 2 things. One is like you have seen, first of all, you have shown a very good summary how to go about the lower urinary tract symptoms. That was very precise and very right. And one thing I would like to ask that as per your slides, alfuzosin was showing less dizziness and postural hypotension as compared to tamsulosin. But clinically, what we have seen is generally young patient taking alfuzosin, they are coming with this first dose syncope or dizziness. So what is your take on it? And second is about this floppy iris syndrome. How to manage it? Because just stopping a symptomatic patient 4 to 5 days before can land him in retention also. So can we switch to naftopidil or something else beside tamsulosin or silodosin? That is my just 2 questions.
So, sir, first regarding the alfuzosin. So, when we see the pharmacokinetics and the dynamics, even if they have selectivity towards a particular alpha receptors, the in vivo versus what we see in our clinics is entirely sometimes a different game altogether. Like even it's in the literature, it has been mentioned that even when in vitro, the selectivity is more towards the alpha 1D compared to the alpha 1A, they still can have an entirely different spectrum of side effects. And I do agree with you. In our practice, we do see that patients with alfuzosin, when we start them on alfuzosin, their ejaculatory functions or dysfunctions are comparatively lesser, but yes, they do have vertigo and dizziness and lightheadedness as major symptoms. Another thing regarding the second, floppy iris syndrome. So I think this is rather, a beware kind of a thing that the ophthalmologists should have, that yes, they should have that history that the patient is taking the alpha blockers, and they should be beware during the surgery that floppy iris syndrome can happen. By stopping 4 or 5 days before, it doesn't make much of an effect. It can still be there. Naftopidil is a good option, or the other non-selective ones, but again, it has to be it should be a consideration when the surgery is happening rather than.
Or I think tadalafil 2.5 something.
Yes, or we can have tadalafil in those patients. But again, most of the elderly age group do have cataracts, and at one or the other point in their history, they might need that surgery. So it should always be a part of their history, and they can be take this in consideration during the surgery itself.
Any comment, Dr. Yashashvi? Dr. Yashashvi, any comments?
Thank you, Sameer sir, Girdhar sir, and NZUSI for including me in this chat. Hemant sir, just to
clear the point, sir. Whatever you are asking, sir. Sir, I have seen in our clinical practice in BHU that the most common cause of discontinuation of symptom is basically dizziness and asthenia in the elder patients, and I think it is the rate of fall of the BP. The rate of fall of the BP, which is associated with these two symptoms expressing themselves. So we have our cardiac colleagues, and we have discussed this in extensive meetings with them. So they had come to a conclusion along with their own set of studies that it is actually the rate of the fall of BP which is to be seen. And then if you can have a look at that, then the rate of discontinuation of treatment can be a little tingled upon with. And the other thing is in the floppy iris, sir, since we are in talks with our ophthalmology colleagues, they say that it is the blockage of the alpha 1A in the iris dilator muscle, which is a unique muscle. As I do not know the nitty-gritties of that muscle, what histologically it is, but they have been doing some studies. So they say that the iris dilator gets permanently damaged because of if the duration of treatment is more than 13 to 26 months.
That is why I was saying that we can use alpha 1D or something else.
Yes, sir. Yes, continues. Yes.
Thank you.
Thank you, Dr. Anuj, Dr. Hemant, Dr. Yashasvi for this insightful session. And we'll be moving to the next session, that is the uroradiology, CT and MRI, particularly for a urologist. And the speaker is Dr. Tarvinder, he is Assistant Professor of Radiology at PGI Chandigarh. Dr. Tarvinder, and the experts for this session are Dr. Anup Kumar, Dr. Nayak, and Dr. Uday Pratap Singh. Dr. Tarvinder, please.
Yes, sir. Am I audible, sir?
Yeah, you are audible. Your slides are visible, but make it full screen. Yeah.
Okay, sir. Okay.
Yeah. Go ahead.
So I will be presenting on uroradiology. Thank you for the kind introduction, sir. So radiological armamentarium, we have radiography, CT, MRI, and DSA. I will be mainly discussing upon the CT evaluation of renal masses and MRI prostate. And the common CT protocol which we use is non-enhanced scan followed by injection of a contrast, which is 100 to 120 ml of contrast is given at rate of 2 to 4 ml per second, followed by a subsequent scanning of the patient in corticomedullary phase, nephrographic phase, and excretory phases. And since the patient is scanned at multiple intervals, so the radiation dose is quite high in such patients. So there is a technique for that. We can use a split bolus technique in order to reduce the radiation dose to the patient, where we give a 30 ml of IV bolus of a contrast, and we ask the patient to walk for about 10 to 15 minutes, and then do a dynamic contrast CT after giving additional 70 to 100 ml of contrast. Now, the use in this technique, the advantage of this technique is that the contrast which we have given 10 minutes before will be already be in the excretory phase, and it will be opacifying the PCS of the kidney, so that one excretory phase will not be required to scan separately. So in CT evaluation of renal masses, we need to identify the phases of the scan. The first image we can see that just a minute. First image we can see that there is a contrast within the aorta, and the cortex of the kidney is enhancing, medulla is not enhancing. This is a corticomedullary phase. And the second image, we can see the medulla is also enhancing, similar to that of the cortex. This is the nephrographic phase. And in the third image, we can see the contrast within the PCS. This is the excretory phase, which starts usually at
Dr. Tarvinder.
Yes,
So,
yes,
sorry
sir.
to interrupt, but can we move from the presenter view to the main view so that we can see the bigger images, people?
Okay, sir. Just a second. Now it's okay, sir?
Yeah, that's perfect. Thank you.
Okay. Thank you. So these are the different phases of the scan: corticomedullary phase, nephrographic phase, and the excretory phases, which are required to evaluate the renal masses. Now let's discuss the pros and cons of different modalities first. Ultrasound, yes, it is an initial imaging modality of choice to screen renal pathologies, to look for kidney, ureters, and bladder, because it is easily available and it has good sensitivity in experienced hand. But it is less accurate to characterize the renal masses, which are especially small, and it is operator dependent, and it is difficult to assess pathologies in patients who are obese and have lots of bowel gas. CT, yes, it is a gold standard for evaluation of renal masses, and it is used to clarify all the hypoechoic masses or complexes that do not fulfill the sonographic criteria for simple cyst. And protocol which we have already discussed. Yes, there are limitations that it gives radiation exposure to the patient, and iodinated contrast is required for the CT evaluation. MRI, yes, it has a superior intrinsic soft tissue contrast, and we can actually characterize the lesion, and the chemical component of the lesion can also be characterized, such as microscopic fat can be analyzed with the help of chemical shift imaging, and it is good to evaluate, good for the evaluation of complex renal cysts, and it does not provide radiation, and it is a problem solving tool in some patients, and it is very good for children and pregnant patients. Now, when we are evaluating renal masses in adults, we need to characterize the lesions, whether they are cystic appearing or the solid appearing, and both can be benign or malignant. Now, there is a classification for that, Bosniak classification, which separates the cystic lesion requiring surgery from that can be safely ignored or followed up. And proper understanding and application of Bosniak classification is a key step in the management of cystic renal masses. Now, I will be discussing few cases. So this was a patient where ultrasound was done, and we found that there is an anechoic cystic lesion seen arising from the upper pole of the right kidney. And this is a corneal reformatted image where we can see a hypodense cystic lesion with no enhancing septations, calcification, solid component within the lesion. And this was a type 1 cyst. And these are benign, and the chances of malignancy are nearly zero. So this is another patient where on the right side, on the left side, we can see that there is an exophytic cystic lesion arising from the right kidney, and it has some foci of calcification, and subtle hairline septations were seen. And this is a feature of a type 2 cyst. And on the right side, we can see that the calcifications in the lesion are slightly coarse, which is a feature which classifies the lesion into a 2F category. 2F lesions we have to follow up because they have chances of malignancy approximately 5%, less than 5%. And in third patient, we can see that there is an exophytic lesion seen arising from the midpole of left kidney. It has multiple septations within it, which are showing variable thickness and are also showing enhancement. This is a feature of a type 3 cyst, and they have high chances of malignancy, and their chances of malignancy are around 50 to 60%. Now, this is another patient where there was a cystic lesion arising from the midpole of the left kidney, and on NCCT image we can see multiple pores calcification, and on contrast enhanced scan we can see that there is eccentric nodular enhancing tissue, which is very suspicious for malignancy, and this is a type 4 cyst, and the chances of being a malignancy in this case are approximately 90%. So there is a general approach to renal cysts. Bosniak type 1 to 2 cysts we usually ignore. 2F we have to follow. 3 and 4 we have to excise it. So coming to the solid lesions, these can be benign or malignant. They can be classified into balls and types of ball versus bean type of lesions. Ball type of lesions are commonly the renal cell carcinomas, cysts, AML, abscesses, metastasis, and xanthogranulomatous pyelonephritis or oncocytoma. And bean type are lesions those which maintain the reniform structure of the kidney, and these includes transitional cell carcinoma, infiltrative RCCs, and uncommon ones are squamous cell carcinoma, lymphoma, metastasis, and medullary carcinomas. So we have to remember RCCs which deform the shape of the kidney, and transitional cell carcinoma which will maintain the shape of the kidney. So this is a patient who presented who was evaluated for multiple lesions in the kidney, and on CT we found multiple fat containing lesions within the kidneys, and these are classic for an angiomyolipoma. And on the angiographic maximum intensity projection image we can also see that multiple deformed vessels, pseudoaneurysms were also seen within the lesions. These are very, very important to report, and because these lesions have tendency to bleed. The AMLs who have AML which are of size more than 4 centimeter, and aneurysms which have size more than 5 mm are the chances of rupture and bleed are quite high. So this is another patient where we can see that there is a well-defined hyperechoic lesion arising from the mid and lower pole of the left kidney. and subsequently CT was done for this patient. We see there is a enhancing lesion rising from the mid pole of the left kidney. Now, important point to note here is that the enhancement is relatively less in comparison to the cortex of the kidney. So it is hypo-enhancing as compared to the background kidney. And also we can see there is a hypodense scar within the kidney, within the lesion, and few hypodense linear strands giving a spoke wheel kind of pattern. This is classic for oncocytoma. Now, this oncocytomas are usually have imaging features which overlap with the chromophobe type of RCC, which we will discuss in the subsequent slides. Now, malignant renal neoplasms, they can be primary or secondary. Primary epithelial tumors like renal cell carcinoma or transitional cell carcinomas or sarcomas, and secondary involvement of lymphoma or metastasis. Now, histological subtypes, clear cell RCCs are the most common, and they are 75% of the times they are seen, followed by papillary RCCs, chromophobe, renal medullary carcinoma, and collecting duct type of carcinoma. Can we differentiate these histological types on imaging? Yes. They have certain features which point towards that this RCCs of clear cell type and others are of papillary type. Now, this is a case this patient presented with hematuria, and this is the NCCT image. This is a corticomedullary phase, and this is a nephrographic phase. We can see that there is a lesion which is having an exophatic component arising from the mid-pole of the left kidney, and on corticomedullary phase, the lesion is showing heterogeneous enhancement with areas of necrosis within it. Now, look the enhancing component of the lesion, which is similar to that of the cortex. This is a very important feature of clear cell carcinoma, that these are hypervascular tumors and will show enhancement similar to that of cortex in the corticomedullary phase, and in the nephrographic phase, they will show a washout. As we can see in this third image, the lesion is showing hypo enhancement in comparison to the rest of the cortex. So, second variety of papillary RCC, we can see that there is a lobulated lesion seen arising from the lower pole of the left kidney, and it also shows a few punctate foci of calcifications, which are very much evident on the NCCT scan. And subsequently, corticomedullary phase and the nephrographic phase was done for this patient. We can see the lesion is enhancing, but the enhancement is relatively less in comparison to the cortex of the kidney. And on nephrographic phase, it is still hypo-enhancing. So this feature, that hypo-enhancement, is a very important feature of a papillary RCC and chromophobe RCC, which we will discuss in the next slide. The important point to note here is that heterogeneity of the lesion. This appears quite heterogeneous. So this is a papillary RCC. Now, coming to the next case, this again is a hypo-enhancing lesion arising from the right kidney mid-pole. And in comparison to the previous case, we can see the lesion is relatively homogeneous in comparison to the previous case. And this is a chromophobe type of RCC. Now, I have mentioned in the previous slide that chromophobe RCCs are difficult to differentiate from oncocytoma, and it is quite challenging. We cannot, at times, we cannot differentiate both the lesions. So it is very difficult. So this is a coronal reformatted image where we can see that there is an ill-defined enhancing lesion seen arising from the left renal pelvis, causing gross heteronephrosis of the left kidney, and there is hypo-enhancement of the cortex, and this is a case of transitional cell carcinoma. Now, sometimes there can be secondary involvement because of a systemic disease. These are different patients. We can see that there is a hypodense mass seen in the left para-aortic region, and there are multiple lesions seen involving the kidneys involving right as well as the left kidneys. And this is another patient where we can see that hypodense soft tissue which is encasing the right renal artery, and there is a hypodense soft tissue which is seen in the right perinephric space. So this is a picture of a lymphoma. It can present like this. Now, coming to prostate. So this is the axial T2 weighted images for the prostatic anatomy. This is the urinary bladder, and these are the seminal vesicles. And now, looking at the prostate, this is the peripheral zone, and this is the central gland. Remember, peripheral zone will be bright on T2 weighted images, and normally it should be bright. Central gland will have mixed signal. It can have hypointense, isointense, or bright signal depending upon the glandular or the stromal component. And anteriorly, we have fibromuscular stroma. Since it is a fibrous structure, it will be hypointense in all the sequences. So this is again another slide to highlight the anatomy. This is the peripheral zone, which is completely bright, normal central gland having a mixed signal intensity. Anteriorly, we have fibromuscular stroma. These are the seminal vesicles, and this is the peripheral zone. So when this is a patient who was a benign, who had benign prostatic hyperplasia. Now, MRI is usually not done for the benign prostatic hyperplasia, but we need to note the findings of BPH on MRI so that we do not confuse it with the malignancy. In benign prostatic hyperplasia, we will have multiple nodules within the central gland, which will have variable appearance. They can be hypointense, hyperintense, isointense, depending upon the glandular as well as the soft glandular as well as the stromal component. But the important point here is to look at the margins of this lesion. As we can see there here, the margins are relatively smooth. In here also, the margins are relatively smooth and peripheral zone is stretched out. This was a case of benign prostatic hyperplasia and no suspicious lesion was seen to assign a pyroids category. Coming to prostate cancer, 70% occurs in peripheral zone, 10 to 20% occurs in transitional zone, 5 to 10% occurs in central zone, and multicentricity is quite common. So common indications are high PSA levels with no suspicious finding on DRE and repeated trust-guided biopsies which are having negative or equivocal results. And a multi-parametric MRI is usually done, which includes a T2-weighted sequence, diffusion, and a dynamic contrast enhanced imaging. So PIRADS is a prostate imaging reporting and data system, which was first published in 2012 and was revised in 2015. And currently we have PIRADS 2.1 version, which was updated in 2019. And a 5-point scale assessment is done based upon MRI to look for clinically significant cancer with a Gleason score of more than 7 and or volume 0.5 cc and or extra prostatic extension. Now, dominant sequence, I will talk about this in subsequent slides. PIRADS 1, very low chances of having a clinical significant cancer. PIRADS 5, very high chances of having a clinically significant cancer. 3 is equivocal findings. And 4 and 5 are almost same, but depends upon the size of the lesion. 4 is usually less than 1.5 centimeter, and PIRADS 5 lesion is more than 1.5 centimeters in size. So assessment of DWI score diffusion. Diffusion sequence is a dominant sequence to assess for the peripheral zone, which I mentioned in the previous slide. What is the dominant sequence? For peripheral zone, it is diffusion. And for transition zone, it is T2 weighted score. So these are the, as we can see, the third and the fourth columns. These are the DWI images and these are the ADC map values. In the first image, we can see that there is no lesion, there is no diffusion restriction seen, and this is a PIRADS 1 category. And in second image, we can see that there is a thin linear hyperintense band which is seen on DWI, and it is slightly dark on the ADC map, and it is a benign finding, and a score of PIRADS 2 is given in such patients. And in PIRADS 3, we can see that there is a oval-shaped lesion which is bright on DWI and is subtly dark on ADC map, but it does not qualify for a PIRADS 4 and PIRADS 5 lesion. And in such patients, dynamic contrast enhancement can give us, can tell whether the lesion is malignant or not based upon the enhancement patterns. And in PIRADS 4 and 5, we can see that the lesion is clearly bright on DWI and it is markedly dark on ADC map. And in the PIRADS 5, the lesion is more than 1.5 centimeter in size. When we have to give a T2WI score on transition, T2WI score, a transition zone is assessed on the T2 weighted images, where we can where we have to evaluate these nodules. In the first image, it is a normal appearance of transition zone with no suspicious nodules. In the second image, we are seeing the nodules, but they have very smooth margins. In the third image also, we have very smooth margins. But as we see on the right side, first image, the nodule is having ill-defined margin and also showing subtle diffusion restriction. So this is a suspicious equivocal finding. And in 4 and 5, the lesion is the margins are quite irregular. And look at the diffusion. Diffusion is extensive. It is completely dark on ADC map. It is highly suggestive of a PIRADS 5 lesion. So we will go through few examples. This is a case who had a patient. This is a patient who had a PSA value of approximately 7, and MP-MRI was done for this patient. And we can see there is a thin linear hypointense lesion seen involving the right side of peripheral zone, but there was no diffusion restriction. So since there was no diffusion restriction, and in peripheral zone, DWI is the dominant sequence, a Pirates 2 category was assigned for this patient. So, and in the next case, we can see there is again a ill-defined T2 hypointense lesion seen involving the right peripheral zone at around 7 o'clock position, showed minimal early enhancement as compared to the rest of the gland, but did not show any diffusion restriction. Again, it was a Pirates 2 lesion. And coming to this lesion, this patient had PSA of approximately 14, and we saw that there is a ill-defined lesion seen involving the right peripheral zone, and it has a smudgy appearance. And also on the dynamic contrast images, we can see that there is early enhancement as compared to the rest of the prostate, and it showed marked diffusion restriction and appearing completely dark on ADC map. This is highly suggestive of Pirate 5 lesion. So MRI, yes, it is quite accurate for local staging, and we can assess the pelvic lymph node status for this of the patient, and it can tell us about the whether the lesion is within the prostate or it is having an extra prostatic extension, which will upstage the tumor. So looking for extracapsular spread, we have to look for the neurovascular bundle at the 5 and the 7 o'clock position. On the right side, we can see that there is a focal capsular bulge seen with irregular margins, and there is a hypointense lesion seen involving the right peripheral zone, and this is an extracapsular spread. And seminal vesicle involvement, we can see that the lesion is involving the right side of seminal vesicle. This is a seminal vesicle involvement. And this is another patient where we can see that there is a large lesion which is rising from the right peripheral zone, and it is involving the neurovascular bundle, and it is also extending till the level of and it is also showing loss of fat planes with the rectum. So this is again an example of extracapsular spread. And in the MRI, we can also examine these bone metastases. This is a T1 weighted image, and this is a T2 weighted image. The vertebrae should be bright, but they are showing multiple hypointense lesions on both the sequences, which is suggestive of metastasis. And bone scan, yes, it can predict blastic metastasis. So to conclude, ultrasound, it is a good screening modality for examination of renal pathologies and bladder, but it has its own challenges. It is operator dependent. CT is the workhorse in evaluation of renal masses for characterization, extent, and staging. Urography is good to evaluate PCS, ureter, and bladders, and MRI is best to evaluate prostate, and we can give a Pirate score and can label that, can predict the chances of malignancy in the prostate. Thank you.
Thank you, Dr. Tarvinder, for the excellent demonstration and talk. And we'll be taking the comments from the experts. Meanwhile, you can go through the comment box and be ready to answer those chat box questions. Dr. Anup, any comments, sir?
So, first of all, I want to thank the North Zone Council, Dr. Bora and Dr. Kanwaljit for inviting me here. Very, very good, comprehensive summary presented by Dr. Tarvinder Singh on this subject. I just wanted to highlight 2-3 things. In renal masses, the biggest challenge we have is to distinguish between Bosniak type 2F and type 3. That is something which always, there is a query, and then you go for MRI and other imaging to find out, I just want to highlight that thing, that 2F and 3 is something which still we have a challenge, and still the CT scan is not good enough. Sometimes we go for MRI, sometimes we go for even PET scan. I've seen some centers going for PET scan just to find out, so this is one. And I think the role of MRI in prostate has already been established, so I totally agree. There's no doubt about that. And Pirate scoring, only problem is the reporting thing, and I think that's something our radiologist needs to be more trained, especially for the Euro radiology part. And otherwise, I think very well summarized. Thank you.
Any comments, sir? Dr. Uday, sir?
Yeah, nice presentation, Dr. Tarvinder. Your images were really nice and representative, and they are very crisp. And I just want to make comment because you told that it's difficult to make a diagnosis of oncocytoma versus whether you are dealing with the chromophore or other kind of tumor. So in that case, you can get the MEV scan actually. So that is the where you can get the lit up in the because of a lot of mitochondria in the oncocytomas. It leads to a lot of lit up in that actually. So you can make a differentiation in that. Second thing is that if you want to have any confusion regarding the CT images, so it's better to go and yourself on console actually and try to find out actually before any kind of partial affect me or you whether you are going to for the don't affect me, because it's very important. Sometimes you can miss the accessory renal artery or 2 or 3 renal arteries. So it's very important. So try to go and see yourself on console.
Nayak, any comments?
Thanks, Bora. Actually, this is nothing to comment on the presenter because he has actually, it is difficult to cover uroradiology in a 220 minutes presentation, but he has done extensively well. But since this is for the residents, I would like to say something. Whenever you are actually given for particularly for the CT of the for the renal masses, whenever it is given, the only thing that you need to remember, you should know how to distinguish between a TCC and RCC. That is a must. So the TCC usually are hypo enhancing and the RCC are more enhancing, and TCC usually you see the reniform shape is usually maintained because it's within the PCS, and there is always a hydronephrosis. If you find hydronephrosis in a renal mass, you should always suspect there could be some TCC component if it is a hypoenhancing tumor. And he has extensively explained about the other things, but whenever you are reading an CT, you should also look at the other side of the kidney because this is actually exercise for your exam. So you should discuss regarding the other side kidney if it is functioning or not functioning. And when you are looking at the renal lesion, you should look if there is any fat content. So that will help you distinguish between your RCC or your angiomyolipoma. And particularly if you are looking at a small renal mass, you should always give a scoring or renal nephrometry score. And regarding your MRI of the prostate, it is very difficult even for the radiologist to look at the MRI to give a pirate scoring if those who are not routinely looking at it. So for you, it is not your job always actually to be expert on MRI of the prostate, but when you are reading an MRI, you should see know the sequences that is been shown to you. If it is a T1, T2, or if it dynamic contrast image, or if it is DWI or ADC, how does it look like the lesion looks on DWI or it is in ADC, and the T2 image, look at the zones, what the zonal anatomy, transitional zone, peripheral zone, those are the little bit of things when it is given in the exam, it will be asked. So you have to be very careful in looking all those details. So otherwise this exercise was very well conducted and he has extensively discussed all those details. Thank you, Bora.
Sir, yes, I would like to add one comment if there's permission. Yes. Sir, there is a comment regarding CUS. I have not covered that topic in this presentation. Yes, CUS is very useful in characterizing indeterminate lesions such as 2F or type 3s, and it is quite challenging to, as Sir has mentioned, 2F and 3 versus 3 lesions are sometimes very difficult to characterize on CT and MRI also. In such cases, CUS is a very good modality where we can see the CNA images, and we can it's actually a dynamic scan where we can look the enhancement live, and we can predict the chances of malignancy in such patients.
Okay.
Yes.
Yeah. Thank you, Dr. Ravinder and the experts for their insightful talks. And I would like to go back to Dr. Samir for the final vote of thanks.
Thank you, Dr. Girdhar. Very well conducted, and I hope the whole session achieved the objective, and which was mainly meant for the benefit of residents. Since we are way beyond time, and I think it happens every time there is an interactive session that the time limits are difficult to follow. So I won't make a lengthy comment, but I would definitely urge all the residents and even the faculty, if they can provide us feedback in the form which has been provided, that can help us improve such presentations. And I thank all the invited faculty as well as all the attendees for this. And the final comment goes to the President, Dr. Kanwaljit, to close the session.
Good afternoon, everybody. As I will go, whatever Dr. Samir said, it was an interactive session. I was from the start till the end. I may have joined late. Everybody must have learned it. It was very useful for the residents. I wish all the success to Dr. Samir Trivedi, who has started this whole program. We will request your feedbacks because that will help us to become better. And we are here to increase your education in urology, especially for the residents. And I would like to congratulate all the creators of this webinar, Dr. Bora, Dr. Kamaljeet Singh Kaura, under the able guidance of Secretary Sir Dr. Samir Trivedi, and all other members and the speakers who have contributed. And all the best for the next webinar.
Thank you, sir.
Thank you, Girdhar, once again. Thank you, everybody, for attending, and hope a good Sunday. Thank you.
Thank you. Have a good Sunday. Bye-bye.
Okay, good afternoon. Thank you.
Bye-bye. Good